Good morning, dear friends. I'm Dr. Sai Kumar. I'm president of the Cochin Ophthalmic Club. And welcome to this very unique CME program on research methodology. At the Cochin Ophthalmic Club, during the last one pandemic year, we have been at the forefront of conducting 3 to 4 CME programs every month. And we are continuing the second year of the same programs, and this is the first after the Drishti, which is the state conference of the KSOIs. We are indeed fortunate to have the new president of KSOIs, Dr. Babu Krishna Kumar, with us today. And for the KSOIs also, this is the first official program since he took over as president 2 weeks back. So I request Dr. Babu Krishna Kumar to officially inaugurate this program. And then Dr. Gopal will take you through the introduction of the faculty and the topics in detail. So, Dr. Babu, please join us, sir.
Respected dignitaries, my dear friends, this gives me immense pleasure to inaugurate the first CME of the year, just 16 days after assuming charge of KSOI's president. Thank you, Dr. Sai Kumar and Dr. Gopal. COC's Super Sundays were immensely popular last year, and PGs are thrilled to repeat the same success for this program this year too. KSOIs and KJO are happy as their prime project, editing and writing in a journal, happens to be the theme of the first Super Sunday. It shows how much the topic is in demand. KSOIs and KJO has announced 3 courses for upcoming writers and editors of KJO or any other journals. We want to raise the standard of KJO as well as its contributors. My special thanks to Dr. Sudha, editor of KJO, for her dedicated duty for this course. We have the best available faculty in Dr. Namrata Sharma, Dr. Santosh Honwar, Dr. Praveen Nirmalan, Dr. Sabyasaji Sengupta, Dr. Marin Dixon, Dr. Sudha, and Dr. Manu Raj. Thank you, COC, for inviting me to inaugurate this function. I declare the CME inaugurated. Let us march to the pages of journal. Thank you.
Thank you so much, Babu sir. And I now request Dr. Gopal to take over, introducing the faculty and the topics.
Thank you very much, Dr. Sai. Without any further delay, we will go directly into the program. This Super Sunday is designed to be a research methodology awareness program for a lot of postgraduates across the country, and also all the consultants of different specialties who are geared up to do some study. So that's why we have named it From Conducting a Good Study to Writing a Paper. So that requires initially a critical review of the literature. So we start with how to read a paper critically with Dr. Manu Raj. So Manu Raj is currently the professor and senior consultant in the Department of Pediatrics and Health Sciences Research at Amrita Institute of Medical Sciences. He did MSc in Clinical Epidemiology from the McMaster University and Canada Hope International Fellowship for the Outstanding Clinical Researchers for Developing Nations in 2010 to 12. He has about 55 publications with 8,500 citations, an ideal person to actually look at it. He is the associate editor of the BMJ Pediatrics, and he is personally mentored by the great Salim Youssef. Okay, so over to you, Dr. Manu, to tell us about how to critically evaluate each paper that we read. You can unmute yourself, Manu.
I've unmuted. Yeah. So thank you all for this session as an opportunity. Thank you, Gopal. And is my slide visible?
Yes.
Okay. Yeah. So gratitude Institute have mentored me, Amrita Institute of Medical Sciences, the Population Health Research Institute, and the McMaster University, Canada. When we do a research paper, it always starts like this. I mean, this is a classic expression by which we in our early days looked at a paper. And most of us also have a varying levels of ignorance when it comes to deciphering it's written by somebody else, and we are trying to decode it from our perspective. So there is a bit of elephant syndrome in every paper. So each week, more than 12,000 new articles, of which 300 RCTs are happening, are appearing in the Medline landscape. That's a huge amount of stuff, and it's not humanly possible to read each and every one. All we have to do is pick and choose wisely. And when we pick an article, how to dissect it in a short period of time. We have been hearing critical appraisal a lot. What is this critical appraisal? It has been defined as the application of rules of evidence-based medicine in a manner, in a practical way, to assess the validity of reporting, the authenticity of the methods, the appropriateness of the conclusions, the compliance to standard reporting guidelines, and to compliance with ethical principles. So you have to look at several factors, and the package is called a critical appraisal. And the rules of evidence vary as per circumstances, as per designs, as per situations. There are some general principles to it. So is there a gold standard? There is no gold standard for critical appraisal. You do what is best given your knowledge as well as given the scenario of the study. And these criteria evolved with improvements in understanding of important sources of bias. When we were critiquing a paper 50 years back, there was limitations in knowledge. But 10 years later, maybe we would be looking at more forms of bias, which would be discovered in due course of time. This is an evolving thing. So every new day, we are seeing new and new issues with bias, designs, and stuff like that. And it's nice to have a structured approach to critical appraisal, which is essential to improve the quality of that particular process. The anatomy of an original research paper looks just like a fish. I mean, you might wonder what's the relationship between fish and a paper. Body, you have a long trunk, you have a tapering part, and you have the tail. And a paper is also, research paper is also just like this. The anatomy of an original research paper, if you look at this way, it's from head to tail as introduction. Why are you doing this study? What is the purpose of this? What is unknown? How and why are we doing this study? What are the methods? What are the results? What are the discussion things? How can we conclude? And what is the supporting information in terms of tables, figures, appendices, and the list of references that we've been using to introduce as well as to discuss the stuff. So this fish is what we see as a research paper. If you look at the general structure of a research paper, you know it starts with the title, abstract, keywords. Then you come to the broad structure of it, which it starts with introduction, methods, results, and discussion. And then you conclude in acknowledge, and you have your reference and the supplementary data. So there are 10 questions which you will be asking every paper. So it is just like you have a set of questions. Like the first one is the study questions relevant, which is very important. Second is, does the study add anything new, and is it novel? The third is, what type of research question is being asked? You try to decipher the character of that research question. And fourth is the appropriateness of the study design. Was the study design appropriate? Many times we see that, when you see a published literature, you suddenly realize that the study design was inappropriate. You cannot repair that. So you have to ask each and every manuscript, is the design appropriate for the particular type of question presented there? And the fifth question is, did the study methods address the most important potential source of bias? Bias is the killer out there. It spoils the soup. You know that, in a bunch of apples, just one is enough to spoil the juice. Same thing like bias. A little amount of bias is okay, but bias, if serious, will destroy your paper like anything. There is no point in presenting your paper well if there is a bulging bias out there. The sixth question is, was the study performed according to the original protocol, or are there any protocol deviations? And if so, are they mentioned? Are they justified? And the seventh question would be, do the study have a stated hypothesis? It may not be the case all the time, but if you're looking at an analytical study, it has to have a stated hypothesis, either null or the alternate. And the 8th question would be where the statistical analysis performed correctly. 9 would be, do the data justify the conclusions? 10 is, are there any conflict of interest? So you have to remember these 10 questions. The first question is the research question relevant? And in order to know that a research question is relevant, you should know the basics stuff out there. Is this an important topic and is it adding to what is already known? It's a subjective opinion. What might be crucial to me may be irrelevant to you and vice versa. So the first question is to ask is the topic relevant to one's own field? And these are typical things. I would look at all 4 of them with different sense of seriousness. And I would probably look at the last one with more importance. Then I would move on to obesity, which is my theme. So it depends from person to person. The second is, does the study add anything new? New ideas and knowledge in medicine are often developed from basis of previous work. We know that landmark studies are a rarity, and most of the time we are looking at incremental evidence. Somebody has discovered something 80%, you're adding 10% to make it 90%. For example, and some studies may just replicate, and you would say, no, just a replication study, I'm not interested. No, a replicating study is also important. It enhances the validity of the previous research. It also enhances the ability to generalize the prior research findings. So you look at different studies, you can see that some of these studies are being repeated again and again. It adds to the credibility of the previous information. It adds to the generalizability of that. And third is, what type of research question does a study pose? This is a fundamental task. The process will determine the optimal study design. To assess where a study design is appropriate, you should have a basic understanding of the common study designs from descriptive to analytical. In analytical, you may come across case controls, cohorts, or cross-sectional, or diagnostic accuracy studies. In the experimental one, you may see a non-randomized RCT or an RCT. So you should have a basic understanding of the designs and ask, is the research design appropriate here? If yes, that's better. So the final criteria for a research question is just 5 things. The study question and the study should be a feasible one. It should be interesting to the particular specialty that's out there. It should be novel in the sense that there is some new information added. It should be ethical in the sense that we are not harming a single participant if it's a human trial, or an animal if it's an animal trial. And if the study results are relevant for the patient you're going to treat the next day. So a finer criteria, you should run every research question presented in a paper through the finer, it's like a sieve. And if you could see all of these categories satisfied, that's a good research question. Sometimes in interventional studies, you may look at the Picard criteria, which is basically population. What is the study population described here? The intervention. Are they looking at an intervention? Is there a comparison intervention like a drug versus the placebo? What are the outcomes of interest they are looking at? I mean, what are the factors that they think will change up or down with the particular treatment versus the other treatment? What is the time period of that particular intervention, and what is the overall combination? A non-interventional study may not have this Picard criteria because there won't be an intervention, there would be an exposure, and there would be an outcome. So basically, you have to ask the finer and Picard questions and then tell this research question is perfect because it looks at the finer and Picard rather authoritarian. Was the study design appropriate? This is a difficult question because you should know the hierarchy of designs and you should know some bit about the designs. But most of the time, we have a blind feeling that RCTs are the best. A systematic review of the RCT or meta-analysis of well-conducted RCTs is the perfect one. Then comes the cohort, which is prospective and retrospective. Then could be the case controls, different types of it. Then could be cross-sectional ones. And then could be some case series, case reports, or anecdotal evidence or descriptive reviews. So the hierarchy of evidence, you have a gold up there, and it comes to silver, copper, and then finally basic stuff. Personal experiences, virtually nothing. So the pyramid of evidence, higher the level of that particular study design, better the paper is. Then you ask this question, did the methods address potential sources of bias? This is very important because bias is like an impurity in a study. And there are 2 types of bias, something that happens randomly with measurements, which we call a random bias or a random error. Like a BP measured multiple times, different readings, that's random error. Systematic bias is some error that happens due to systematic nature. There is a direction to it. A faulty BP machine giving you high readings all the time or low readings all the time is an example of a systematic bias. So does the study have enough occurrences of random bias or systematic bias? Have they mentioned some methods to report that? Have they did something to reduce the random bias as well as systematic bias? So you have to say whether there is a bias, were the authors aware of that bias? Did they do something to reduce the bias? And do they have proof that they have reduced the bias? All these questions happen here. This is very tricky because it keeps changing depending on the study design out there. So key methodological points, if you are examining a systematic review which has a meta-analysis, is that where all relevant studies included, like, in a meta-analysis, you plug the studies from internet using a search strategy, and did they include all the relevant studies? Was the search appropriate? Was selected articles appraised and data extracted by at least 2 independent reviewers? Was sufficient detail provided by the primary studies, including description of patients, interventions, and outcomes? Was the quality of the primary studies assessed and a quality table presented? Did the researchers assess the appropriateness of combining results to calculate a summary measure? Sometimes, a meta-analysis is just like you take a bunch of studies, put them in a mixer, make them look like a large study with all the participants. And that's a nice way to collect information and make an authoritarian conclusion. Sometimes the studies are so different, you may be finding it difficult to mix them. In that case, what we would do is we would report on something called a heterogeneity of that. And then say, we are sorry, we cannot pool all the studies. So we are refraining from a mixed analysis. We are not doing a meta-analysis here. That's also okay, because you are not supposed to mix studies that are not to be mixed. So this is an example of circumcision and HIV infection. One study says that there is no to circumcision. The next one says yes to circumcision. And the third one, a meta-analysis out there, says definitely there is a role for circumcision. This is how research goes on. You might see yeses, you might see no's, but when you pull all the yeses, no, with all the available study, you might even get a different conclusion, which is more robust and appropriate. So if you look at the key methodological points, the next study design, which is a randomized controlled trial, and I hope you have a basic understanding of a randomized controlled trial here. I don't have the time to describe it. You basically look at critical things like treatment allocation. Would participants have been able to know or guess the treatment allocation? Were the participants blinded? Like, who knew what is drug, what is placebo, who got the intervention, who didn't get it? And where outcomes assessed objectively or subjectively. An objective thing is quite different from a subjective thing. One is hard evidence, other is soft evidence, liable for variation. And where all participants who were randomly allocated in the treatment accounted in the final analysis, excluding a single patient, whether or not he received an intervention is problem. So you have to always look at the number of people excluded from an RCT, and where all participants data analyzed in the group to which they were randomly allocated. You allocate somebody randomly to one group, they should stay there even at the end of the allocation, whether or not they receive the intervention. So this is an example. There is something called intention to treat comparison, where everybody in a particular group is treated as that way, whether or not they receive the intervention. In a per protocol comparison, we only look at people who satisfied the protocol as 100%. That is a selective kind of analysis, which is bound to get you a biased thing. So if you move on from that to cohort study, you have to ask the bias questions like, is the study a prospective one or a retrospective one? Prospective studies are more dependable, retrospective studies are less dependable. Is the cohort representative of a defined group of population, or is this cohort a skewed one? Sometimes the cohort may be a skewed one. You may not be able to generalize the findings from that study to the outside world. That is a problem, where all important confounding factors identified. When it comes to observational study designs, confounding comes along with that. It's a package that comes along with that. You're not inviting confounding, because confounding always comes on its own. So every observational study design should have plans to identify confounding, to document confounding, and there should be approaches to minimize confounding. So are the authors aware? Did they do something? Did some benefit occur? What is the proof of benefit of the reduction in confounding is very important in all observational studies, cohort included. And then you ask whether the measurements were accurate and objective in all members. What is the loss follow-up? And conventionally, cohort studies with follow-up loss beyond 20%, people don't trust them to the way they would like to. Anything less than 70%, that entire study design is destroyed. So ideally, you should be targeting to a follow-up of at least 90% and above when you're talking about a prospective cohort study. And then participants followed up for a sufficient length of time for something to happen. You know, for lung cancer to occur, you need people for 20 years. If you do a short cohort study, you're not going to pick up lung cancer from smoking. So always look at the time given in the cohort, and was it enough for the outcome to happen in sufficient numbers for making a reasonable comparison. So this is an example of a failed one. This is the nurses' health study, which first said that, you know, you give oral contraceptive hormonal pills to women, you reduce their cardiovascular risk. This is a totally flawed study, and this is a classic example of confounding. And when we really did a clinical trial, it is exactly the opposite. Any woman in the postmenopausal age given hormone supplement actually had an increase in cardiovascular risk. This is a classic example of an observational study saying yes and a randomized controlled trial saying no. So you have to be very clear about it. All study designs are flaws, and always the superior study design is more likely to tell you the truth. The key methodological points in a case control study is that compartment thing, it's the retrospective study design. You have cases of a particular illness or a disorder. You have matched controls or an unmatched controls who don't have the condition. And you compare the two groups and look at a particular exposure. Like you have lung cancer patients, you have no lung cancer patients. You compare the exposure, which is smoking. Is the smoking prevalence between the cases and the controls different? If the prevalence of exposure is different between cases and controls, you end up saying there is an association between the disease and the exposure. There is an association between lung cancer and smoking, or smoking and lung cancer, vice versa. So you have to ask whether the cases are clearly defined, whether the case is representative of a defined population. Study measures identical for cases and controls, where study measures objective or subjective, and a recall bias is likely the subjective. So you should know that when you pick cases and controls for a case study, what you basically do is you look at how good are the cases. And this is an example of the world's largest or most popular in the hearts study, which is the case control study. In this one, you can see that they look at multiple risk factors for myocardial infarction. This is one study that told the outside world that these are the major factors: smoking, like hyperlipidemia, high blood pressure, obesity, stress, ApoB/ApoA1 ratio. All these factors are linked to myocardial infarction. The study that exposed all these risk factors is the in the heart study. So key methodological studies of a cross-sectional study design, you have to look, the study sample, is it clearly defined? Is the cross-sectional survey representative of a real one, where all relevant exposures, potential confounding factors, and outcomes measured accurately, where patients with a wide range of severity of disease assessed. So when you look at a disease, people usually tend to pick either mild disease or moderate disease, something like that. You know, a proper cross-sectional study should have a spectrum from mild to moderate to severe to lethal versions of any particular disease to improve upon the generalizability of them. So key methodological points in a case series is it prospective or retrospective? Is it representative? It is similar to patients in your practice, where all the exposures, confounding, and outcomes measured accurately. So there are some studies called diagnostic accuracy studies, where you compare one type of diagnostic accuracy method with another, like X-ray is compared with ECG, ultrasound is compared with CT scan, maybe echocardiogram is compared with ECG. So you have two diagnostic methods. One is gold standard, other is a new one. So compared to the gold standard, you are conventionally reporting parameters like sensitivity, specificity, positive predictive value, negative predictive value, and diagnostic odds ratio, stuff like that. In such a diagnostic comparison study, you look at whether all spectrum of the disease has been included? Was the gold standard really a gold standard? Was the gold standard and the comparing test done in all people in the same manner? Were tests performed independently with blinding of assessors? Sometimes assessors might look at one arm and say, I think this arm is more appropriate, more accurate, and be biased. So assessors should never be given the outcome source of the type of diagnostic test, and where the cutoffs that we use as appropriate or not. So when we conclude the study design specific questions, you come back to question number 6. We were discussing question number 5 in detail. Now the question number 6 is, was the study performed in line with the original protocol? It is always nice to write a protocol, get it cleared, and put it up in the internet for others to see. If you could publish your study protocol, that's the best, because tomorrow when you publish a paper, you can tell people that the protocol was published earlier and we haven't deviated a bit from it. It's okay to deviate, but you have to tell in the paper the reason for the deviation, what was the pressing circumstances, and what measures were taken to minimize the deviation and justify it properly. It should not look like you messed up with the study, then you have to deviate from the protocol. The protocol deviation should appear as if it was an act of science done in good faith with people trusting that deviation from. So deviations always affect the validity or relevance of the study. Sometimes it may be a failure to recruit. Sometimes it may be to improve the generalizability. So sometimes it may be also reduce the power of the study. So you have to be very careful. No deviation is the best. If you deviate, make it less and try to justify it and be transparent. Never hide a protocol deviation. Anybody hiding a protocol deviation, which is exposed later, is bad research practice. The 7th question is, does the study test a stated hypothesis? Most of the study don't report a stated hypothesis. You have to guess the hypothesis from the primary objective. Sometimes when you read papers, they don't even mention the word objective out there. They would rather broadly say vaguely that the aim of the study. There is nothing called an aim of the study in a paper. In a paper, there are only objectives which are listed either as primary or secondary. Always see that the authors have mentioned primary and secondary objectives, because the sample size is calculated for a primary objective, but the analysis includes both primary and secondary objectives. A paper that does not mention primary and secondary objectives is a faulty paper, methodologically incorrect paper. So you should look at the null hypothesis. You should look at the statistical hypothesis testing and the plan, whether the plan was correctly done. And you should also look whether there is too much testing or some missing. Sometimes, the authors will go and do a lot of tests and pick only the positive ones. Sometimes, they would forget to mention some tests out of pure chance. One is error, other is a conscious error. Both are bad, but consciously not reporting negative tests or not reporting tests that were not in line with their belief is also a problem. So you should be very careful whether people have done adequate testing and there was no excess or hand-picking of it. You cannot cherry pick with testing. The 8th question is, where the statistical analysis performed correctly. All qualitative and quantitative research, basically we look at the statistical plan. In the method section, you have 3 paragraphs. You look at the selection and discussion of participants. You talk about the technical information. Then you talk about the statistical analysis plan. You have to say what was the prior plan. And then you have to say what we did in the study. If there is a deviation, you have to justify that. And you should also look for the completeness of the data, what the authors did in terms of missing data. Did they report the percentage, or how did they tackle the missingness of the data in the analytical approach? Everything should be transparent. You miss some data, report it. You did some change in analytical plan to contain it, report it, and you justify it. So you can be, everybody is likely to miss some data here and there. Be open, be transparent, put it out there. And in a paper, look for the transparency and the openness of those people. And original data should be presented in a way that readers can check the statistical accuracy. A very important consideration in RCT is whether you did a per protocol analysis or an intention to treat analysis. I mentioned earlier, intention to treat analysis is the best one. Per protocol is the skewed one, which is less desirable. Statistics for doctors is like an alien thing, a foreign language. We biology people feel there is no need for us to know maths and we are basically maths haters. It's not like the case. You should know a bit of stats, the basic concept, so that when you write a paper, you know what to say. The statistical method always helps the reader understand how the data was analyzed in the practice. So you should also be focusing, most people focus on the p-value of it, the statistical significance. But what is more important is the measurement error and the uncertainty. Uncertainty, you'll see an estimate with a 95% confidence interval. So a narrow estimate is the best one rather than looking at the p-value. The confidence interval tells you a lot more than a simple p-value. And always try to look at the clinical significance of the paper. Statistical significance is just mathematical. The clinical significance is the real benefit the future patient is going to get from the treatment. Are the authors mentioning about the effect size and linking it to the clinical significance? If they are not, they are doing a mistake. Every research paper should have a paragraph on clinical relevance or clinical significance. References for the study design, the sample size calculation, and the statistical method should also be in the statistical plan. Define statistical terms, abbreviations, and more symbols. Specify the package used for the software statistical analysis. Distinguish pre-specified from the exploratory analysis. Pre-specified ones are upfront stuff you are going to say before you look at the data. Exploratory analysis are analysis you do after you see the data. So exploratory analysis is like a little bit of digging. It's not the right way. It should be used for generating ideas for future studies. For the current paper, exploratory analysis does not matter. Exploratory analysis is for the future designs that happen. You can do an exploratory analysis, but tell that this is a minor thing, this is less relevant, this is for the future researchers. They will get some clues from the exploratory analysis. 9 is that do the data justify conclusions. Most of the time, what we see is that they will have a decent result, they will have a decent discussion. Suddenly, you see a very dramatic conclusion which looks like a twist at the end. Always, your discussion should be anchored to the results and your conclusion should be anchored to the discussion. Don't say a single line that is not supported by the data presented in the results. In a conclusion, there are 3 things you should be looking at. What is the summary of the evidence out there? What is the message the researchers want to give for future researchers? Is there a message for practicing clinicians? Is there a message for policymakers? So these 4 components can vary depending on conclusions, but basically these are the 4 things that you see and look in a conclusion. So be nice, be modest, be writing a conclusion that is justified. Just 4 or 5 lines is okay. A small paragraph is fine. Your conclusion should never be lengthy and verbose. It should be point of fact. And that is the paragraph you want people to remember when they forget everything in the paper. Those 4 or 5 lines are the ones you want people to remember. So this is an example of something, and I can show that they had a conclusion in the end which was not linked to their primary objective. Your conclusion should always be linked to a primary objective because they look for something else. They look for mortality reduction. But ultimately, what they found was that in perioperative thing, beta blockers actually increase the risk of stroke. So they end up saying, there is more harm. Instead, they were actually looking for something else. So a primary objective is ignored and a secondary objective is given due importance in a conclusion which is not appropriate. This is one study if I'm a mentor, but I'm open to criticizes. That's how science should be out there. The first one is cardiovascular. This was the main thing they wanted to look, but ultimately you can see that there was an increase in stroke and other things. That is where the study deviated to the other side. 10th one is, are there any conflict of interest? Everybody has conflict of interest. It could either be mild and moderate or severe. Most of the time, conflict of interest is not mentioned. Conflict of interest is simple. Are you going to benefit from the publication of that data, either professionally or economically or in any other manner? If you are likely to benefit from the publication of such data, we usually say that we have a conflict of interest. So conflict of interest occurs when personal factors have a potential to influence professional roles or responsibilities, and researchers must make judgments and safety of participants is at risk, and validity of research findings is also questionable. So potential conflict of interest is extremely common, and you have to recognize and deal with it. Look for open disclosures and conflict management statements. If are out there, if there is an open disclosure, if they're told that they have conflict of interest and what they did, that's fine. That's openness. So this is an example. Most pharma-funded studies have conflict of interest, and you can see that when pharma funds a clinical trial, is most likely going to end up positive. This is a known fact. So be suspicious of anything that is funded by pharma. Have a neutral outlook. Most of the time, studies funded by academic institutions tend to be neutral, and those funded by pharma tend to be on the positive side. Appraisal is a systematic process through which the strength and weakness of a research study can be identified. This enables the reader to assess the study's usefulness and whether its findings are trustworthy. And consideration of the importance of the research to one's own patients will help clinicians identify the most relevant, high-quality studies available to guide their clinical practice. Thank you. And I think I've given you some useful points out there.
Thank you very much, Dr. Manu. It was actually a very eye-opener sort of initial talk where we looked at how we actually look at a clinical study. So once the review of literature is done, then we will go into the next level. So before that, I would ask if anybody in the panel has any questions, comments, or queries. We can have a brief 2 or 3 minute discussion on that, and then move on to the next talk. It's open to discussion. Please unmute yourself and ask or comment. So Manu, I would like to ask you that most of the studies that we have, there will be some conflict of interest. There will be some primary objective, which is not the final focus of the clinical. So whatever you said will be there. So how will you understand, like in all the print media, we will not be able to actually get the initial protocol of that particular person?
Yeah. See, Gopal, this is a tricky question. You know, we have to be sincere to ourselves. There are no referees out there. So if you are deviating from a stated protocol, it is from you yourself. You can say, no, we deviated from the protocol in this instance, and this is the reason. It is better to, because sometimes people might discover it later. If it's not mentioned in the manuscript, it looks as a bad thing. Conflict of interest is tricky. You know, sometimes if you disclose a conflict of interest, the entire study becomes questionable. The best thing is that at the start, you have to ask yourself, am I going to end up with a conflict of interest for this kind of data? Maybe you received a travel fellowship from the drug company that owns this medicine. Maybe you were on a scholarship from that company. Many things can happen. It is okay when it happens, but you can say upfront, A and B received partial funding from the funder on a prior date for this purpose. When you mention that, people know, okay, this person is transparent, at least he has disclosed it out there, then people will read it in that sense. It is not that you should stay away from it fully. It is, the importance is on the transparency of it. You say it upfront, you say this is it, but we ensured that the final analysis and the manuscript was written with due balance in consultation, all that stuff. And there are ways to write it. It's basically a strategical positioning and the proper language with an openness to it.
Okay. Any other questions by any of the
Dr. Manu,
panelists?
just one question.
Yes,
You
sir.
mentioned about that nursing staff study with you know, that hormone.
Yeah.
How can this be totally different when you look at it in different ways? I mean,
this is a dramatic example. So usually it don't happen. This is black becoming white in an extreme case. You know, nurses health study, they thought nurses would be a representative of the general population, which is not. Nurses they're highly informed. I mean, in the Western world, you know that a nurse knows lot of information very close to a medical professional or a doctor. So these people were health conscious, they were eating fruits and vegetables, they're doing exercise, they were doing everything which actually reduced their cardiovascular risk compared, and people thought it is the OCP that they're taking at the menopausal state. But in a proper RCT, they did this on normal females. They did on females randomized, and there is no confounding of this healthy behavior bias. You got it? Suddenly, it shows that there is no benefit. There is slightly
the risk.
the other side. So we have to be wary when this is a classic example of confounding from selection bias. If your study sample is not representative, your study conclusions are also not representative. As simple as that.
Thank you.
Okay. If there are no further questions, let us move on to the next talk. Okay. So next, I will want to introduce you to Dr. Praveen Nirmalan. Hello, can you hear me?
Yeah, Gopal. Yes, go ahead.
Okay. So Dr. Praveen Nirmalan was trained as an ophthalmologist and a vitreoretinal surgeon. He was an MBBS from Thrissur Medical College, my alma mater, and 5 years senior to me. And then he was in Arvind. He then finished a master's in public health and a public health ophthalmology fellowship from the Johns Hopkins School of Public Health, USA. Dr. Praveen also worked in clinical and public health in some of the top tier institutes in the country. He had been a team leader and member of community-based and clinical research in several medical disciplines. And he has developed and chaired ethics committees in different institutions. He has been a clinical and public health research mentor for practicing clinicians and has mentored over 200 MD, DNB, and PhD students. He has more than 100 publications, and about 4,000 is his citation index. Over to Dr. Praveen Nirmalan to speak about clinical study designs, numbers, how do we calculate all those things. Over to you, Dr. Praveen.
Okay, thank you. And let me start by thanking the organizers for giving me this opportunity. And without much ado, let me get into the topic. So the topic that I have been given is the question, the design, and the numbers. I'll give a very brief introductory talk on these three blocks that can cause grief, immense grief, if they're not addressed properly while you're doing the research project. And basically, I'll just throw some stones and you can watch them skip along the surface of the river. It's not going to be an in-depth analysis because it's difficult to do that in such a short time. So we'll throw some stones, we'll watch them skip along the river, but we'll focus on these three elements. And at the very basic foundational aspect of these three elements. So what is research? Research is essentially the search for an answer to a question. And what we have to understand is that the whole process of doing research is something that is aimed at reducing uncertainty. If a very precise, valid answer is a useful byproduct of research, but the whole process aims to reduce uncertainty. And a focus question is the first step to walk along the process to reduce uncertainty. What's a smart question? A smart question is something that is very specific. There is no ambiguity in it. You know exactly what you're looking for. You know exactly what answers you're seeking. It's something that can be measured. It can be measured with the resources that you have in the time frame that you have. It is something that can be achieved where you can get a result. And it's something that has to be very relevant to your local context, to your local population, to a clinical question or a public health question, and something that can be answered in a very specific time frame. The key to developing a good research question is to make sure that you don't bite more than you can chew. So if you can't or don't have the resources to answer a particular question, it's better to try not to address that question at that particular point of time. What are the elements of a good question? The question should give you clarity on the condition of interest that you're looking at. the variables of interest, and the anticipated relationship between variables. So this could be that you're looking at an association, you're looking at a risk factor, you're looking at outcomes, you're looking at therapeutics, you're looking at intervention. So what's the anticipated relationship between variables? The question should also give clarity on who is being studied and if there are particular subgroups that are being studied and the time period the study is happening. The time period is important because if it's not relevant or it's going to take a long period of time where newer interventions might come in, then you need to be very clear and careful about that. And the proposed methods of ascertainment of the measures, especially the primary measures. So as an example, is plasma vitamin C level associated with wet ARMD in persons aged more than 50 years with obesity and type 2 diabetes in Ernakulam district of Kerala in 2020. If you look at this question, you can see that we have the condition of interest. We have wet ARMD sitting there. We have a variable of interest, vitamin C. We have the method of ascertainment, plasma vitamin C level. We have the population of interest, persons aged more than 50 years. We have the subgroups, obesity, type 2 diabetes, where the location, Ernakulam district of Kerala, and a time period, 2020. So the question sort of gives you all the factors that you're interested in, and it gives, and you can use this to get greater clarity on how you want to proceed further. Now, the question is very important because I'll speak from how I look at a question when I review a dissertation or when I read a paper. So when I read a question, it straight away tells me what design would be ideal to answer that question. It has to tell me the ideal design. It gives me an indication about what could be the alternate designs that can be used to address that particular question. From the question, I can frame, and this is what I usually do. I frame my own way of answering that question, the measures, the methods of ascertainment of the measures. How do I plan the analysis? Develop my framework for the results and develop a framework for the discussion. And then I start reading to see whether what the authors or the investigators have done. And so the question gives a lot of information. And if you're not careful about the question, if you're not clear about the question, if the question is vague, a lot of this information gets muddled. And then it sort of becomes clear that the rest of the research might probably not be as clear as it should be. So the question packs a lot of power in its punch. And it's always better to spend time framing the question. And if you spend time framing the question, you will actually save a lot of time developing your research protocol, doing your study, doing your analysis, and finally converting the whole product into a publication. So spend maximum time on framing the question. And then you move on to find the answer to a question. Now, what we have to remember is that specific questions can be answered by specific designs. And if you use a specific design to answer a specific question, you're on the path to obtain specific answers. So it's a clear path. It's clearly defined paths. There are few diversions in between which you can take if you would like to, or ignore if you would like to. But on the most part, it's a clear path from the question to the design to the answer. Let's look at some of the designs. Again, I'm not going into the details of all designs, but I'm looking at just the important points that we need to look at as a basic foundation. The case report and series, something that almost everyone tries to do or has done as part of their initial grounding into research. Description of an event or a person is a report, and if you have more than one person, you may convert that into a series. The case report and the series essentially is a hypothesis generator, and it sets the foundation for further research. The key element in a case report and series is your interpretation of the event or condition that you are describing. And that's the key element that's often missing in a case report or a case series, the interpretative element. And when the interpretative element is missing, then the case report or series loses significance. or does not add much value to what's already out there. So the case report, case series is the basic hypothesis generator, the basic element upon which further research is built to impact on clinical or public health research. The cross-sectional study design that looks at measurements at a single time frame, and it's across a section of people, place, or time. The cross-sectional study design is the ideal design if you're looking at magnitude of a condition, if you're looking at the prevalence, if you're looking at incidence, if you're looking at associations, an association between a factor and an outcome. The cross-sectional design is also the ideal design for diagnostic accuracy or diagnostic effectiveness tests for quality of life, and it's also used commonly in health economics. Within the cross-sectional study design, you have the option to have nested case control designs and a cross-sectional cohort design as well. So the cross-sectional study design by itself can include a case control component and can include a cohort component as well. The case control study. Now, the key element to remember in a case control study is that the outcome, it's a single outcome that you're studying, and the outcome has already occurred. And now you're going to look at factors that have led to that outcome. So you could look at multiple risk factors and a single outcome. With a case control study, as has been told in the previous talk, the definition of a case and a control is very important. It's important to make sure that there's no overlap between the cases and the controls. Selection of cases and controls are important. A very key factor is the documentation of risk factors that are available. And if you're relying on recall, you need to know that what you obtain as results may not always be very reliable or valid. Bias is a very, very, very important aspect in a case control study. The other type of study design that we commonly use is the cohort study design. And in a cohort study design, the difference is that we can look at multiple outcomes. So we are looking at a single factor, and we're looking at the number of outcomes that come from that particular single factor. So it's a single exposure that can lead to multiple outcomes. Again, the definition of exposure and non-exposure has to be very clear and distinct. The groups have to be distinct and discrete so that there is no overlap between the groups and hence no misclassification bias. Selection of the groups is very, very important. Documentation is important. Recall is important. A very important aspect in cohort studies is the element of time. The time it takes to follow up, the time it takes to obtain your results, and the knowledge that interventions, factors can change within that particular time frame. Now, the cohort study is the ideal design if you're looking for study of causality. If you're looking to see if X causes Y, then the study design has to be a cohort study. So the ideal study design for causality. The cohort study design also gives you information on strength and direction of associations, similar to what a cross-sectional study does. But the key element here is that it's a single exposure, multiple outcomes. And then you have the interventional studies. The interventional studies, the main one is a clinical trial. And the key element to look for, something that's not often looked for, beyond the aspects of randomization, allocation, masking, the key element to look for here is superiority and non-inferiority. Trials can be either a superiority trial, can be a non-inferiority trial. If it's a superiority trial, you're trying to say that this particular intervention that I am studying is superior to the control intervention by a specified margin. If it's a non-inferiority trial, you're saying that this particular intervention that I'm studying is not inferior to the existing standard by a specified margin. And the key here is to make sure that you are specifying the margins of superiority and non-inferiority before the trial starts. So you have to be very clear that, well, I'm going to use this particular intervention if it is 10% or 25% more superior to an existing standard. Or I'm it's okay if this intervention is within this particular range, plus or minus 5 to 10%, and is not inferior to the existing standards. So those have to be defined and pre-specified, and these are clinical determinations. A very, very important aspect that is not often reported in clinical trials is the minimally important difference. The minimally important difference essentially is the number of patients that have to be treated with the experimental intervention to avoid one more adverse outcome or one more bad outcome. The minimally important difference can be a clinician's minimally important difference, which is what I just described, or a patient's minimally important difference where the patient adds on what they feel about the outcome, the severity of the outcome. So you say, well, if the outcome was stroke and the adverse event, the adverse outcome of interest is stroke, then they can say that, well, the severity for me was mild or was severe, and that is added on to get the patient's minimally important difference. These are aspects, the superiority and non-inferiority and the minimally important difference are aspects that have to be considered while you are designing a clinical trial. The study of studies, systematic review, meta-analysis, you frame a question, you do a search, you identify the relevant work, you assess the quality of the studies, you summarize the evidence, and then you interpret the findings. Now, the key element here is that the results are entirely dependent on the search strategy that you use. And you have to be very sure that the search strategy identifies high-quality articles. The results depend upon the quality of the evaluation that you do to include or exclude studies from the systematic review or meta-analysis. And the quality is very much dependent on the quality of the primary studies that are included. So if the primary studies are not of a good quality, then the systematic review is not going to give you good results. It doesn't matter that it's a systematic review or a meta-analysis at that point. If the primary studies are not of a high quality, you're not going to get a high quality result out of it, even if your entire process has been correct. So the ability to analyze and understand the quality of the primary studies is important. And that's where the idea of study designs and the elements of study designs and the way then you move forward from the study designs becomes important. Now, most meta-analysis and systematic reviews are done on clinical trials. And clinical trials are done on heterogeneous populations. So oftentimes you end up having several studies that with a high degree of heterogeneity that you can't add them into a systematic review or a meta-analysis. So the design is important. The design is very important because it has specific elements that walk you along a certain path to answer a certain type of question and obtain a certain type of answer. There are several pitfalls. It looks simple. It's something that we have heard often from our undergraduate times, and something that when we hear, we feel that, well, this is simple and this is something that we know. We have heard it so many times. But oftentimes, when we review dissertations or when we review papers, we hit the first block at the design stage itself. And the common pitfalls include an inappropriate design being used, a design that is not appropriate for that specific question. The use of a case control or a cohort design to report on magnitude of the disease, incidence or prevalence, or a mix of questions where you're trying to mix the magnitude of disease with something else, and you're trying to report on both, and then you're ending up having to mix designs. Inappropriate sample size calculations, each design has its own way to estimate sample sizes, and inappropriate sample sizes as well, and inappropriate interpretations. So let's move on to the numbers to a study. And rather than going into a mathematical explanation of this, I'll focus on just the key elements. And key point that we need to remember is that if we study less than required number, if we study less than the required sample size, even true differences might appear insignificant. So people often say, why do I need to study so many patients? Can't I do on a smaller number? And this is a problem with that if the sample size is less than the required number, even true differences might appear insignificant. If you study more than the required number, it's not always a good thing. Even very minor differences might appear significant. It will add noise to the data. And as you try to interpret it, then it becomes difficult because even very small differences show significance. Now, there is an ethical issue as well with sample size estimation. If you're studying less than required sample size, you're subjecting patients to a study where you're not trying to establish a valid result. And then it's ethically incorrect to do that. It's not ethical to do that. It's unethical to do that. If you're studying more than the required number of subjects, as a study continues, you're withholding the intervention that can possibly help some people. You're withholding it from the control group. You're withholding it from people who might possibly benefit from it. So that again is unethical. Also, you're keeping people within a controlled environment when there's no need for them to be within that controlled environment of the study, and they get the benefit of the intervention. So studying less than required is a problem clinically and ethically. Studying more than required is a problem clinically and ethically. And it's always better to study the optimal number of patients. Now, estimating the sample size is based on assumptions that the clinician provides. It's a presumed mathematically derived number that's based on the inputs of the clinician investigator. So the practice of expecting that the biostatistician will give you a sample size has to change to the clinician actually providing all the inputs to the biostatistician to facilitate the biostatistician to do the mathematical computation and give you that number. The mathematical computation can be done using statistical software programs that are available online as well, but you have to give the clinical inputs. And once you give the clinical inputs, then the number comes. So you can see that the quality of the number that you get, the quality of the sample size that you get is actually dependent on the inputs that the clinician provides. So you need to know when you have designed or when you have thought of your question, there's a bit of back homework that has to go in to get these numbers in place. You need to have looked at your data. You need to have your question built on some sort of rationale, and then approach the biostatistician to help you get the sample size. So some assumptions that go into the estimation of the sample size include the power of the study. Power is the probability of making a correct decision to reject the null hypothesis when the null hypothesis has to be rejected and is false. The margin of error, which is a clinical input. You have to tell what margin of error is comfortable for you in your clinical practice. The superiority or non-inferiority margin is again a clinical input. What margin is comfortable for you to make a decision that I will give this in particular new intervention? What margin will you say that, well, it's similar to what is already there, so I would not think of giving this? The least detectable odds ratio or difference, again a clinical input. The ratio of groups between cases and controls, exposed, non-exposed, again a clinical input based on your experience, either in the clinical care field or in the public health field. The proportions, to look at prevalence or incidence, again a clinical input. Measures of diagnostic effectiveness, sensitivity, specificity, again clinical input. So essentially, a lot of the inputs that go into getting a very good sample size are clinical inputs. You have programs that help you to estimate the sample size. Some of these programs include the OpenEpi, Open Source Epidemiological Statistics for Public Health program, PS, a power and sample size from Vanderbilt University. These are free. Stata, a statistical software program, has inbuilt an add-on downloads that help you to estimate sample size. SPSS allows it as an add-on download. So there are several free and commercially available programs available online that you can use to estimate the sample size. But whatever you put in has to come from your clinical experience and your clinical input. And if that is not good enough, what you're going to get out is not going to be good enough. So the key element is that we have to we have to have the transition from listening to actually doing and to practice. And you need to start practicing formulating a question. You need to start practicing thinking what design will apply to that particular question, and then start looking at how do I estimate the sample. There's nothing that comes by just listening to it. It has to be done. And when it's done, it starts sinking in. There's small differences, small difficulty come in the design. It's not as straightforward. A design is not as straightforward or as simple as it sounds. There are elements that come in, and that comes in only as you start doing it actually in practice. So let's look at the question that I put out earlier. Is plasma vitamin C levels associated with wet ARMD in persons aged more than 50 years with obesity and type 2 diabetes in Ernakulam district of Kerala in 2020? What sort of a design would I use? And just to be clear, as a disclaimer, I'm not going to give you an answer here. I'm going to just give you pointers, and I would like you to go back and try to reflect and try to find out what design would work. Can I use a cross-sectional design because I'm looking at an association, and a cross-sectional design is good for an association? Well, I could look at a cross-sectional design, but if I look at a cross-sectional design here, I'm going to have to include people with wet ARMD and without wet ARMD. And I'm going to select a population without knowing how many people have wet ARMD and how many people don't have wet ARMD. So given that the prevalence of wet ARMD is on the lower side, my sample size is going to be large. So I'm going to have to study a large number of people and then check all of them how many have got wet ARMD, and then do plasma vitamin C levels on all of them. And that's going to be time consuming, and it's going to be expensive as well. So a cross-sectional design, even though it's an association study, may not be my first choice. And again, I'm not interested in the magnitude of the disease and discussing the incidence or the prevalence of wet ARMD at all. So I would strike cross-sectional design from my top design. I'll keep it there. I'll come back to you later. Sit on the side, go have a tea or whatever. Can I do a case control design? Well, I'm looking at this plasma vitamin C associated with wet ARMD. Can I look at plasma vitamin C as a risk factor for wet ARMD? If I look at plasma vitamin C as a risk factor for wet ARMD, can I say that my cases are those with wet ARMD, and I'm going to go on a 1:1 allocation and have an equal number of controls without wet ARMD, and I will look at plasma vitamin C levels in these two groups. That sounds good. The only problem is good plasma vitamin C levels have been done for all patients. So I need to plan that to move forward and plasma vitamin C levels done for all patients, and then look back as a case control study and see what's done. Now, traditionally, conventionally, we say case control studies look back, they're retrospective, they're looking back, they're looking back. In this particular case, if I look back the controls, and even a lot of the cases may not have had plasma vitamin C estimation. So I need to plan for that and then look back. So that's one possibility. Can I look at this as a cohort study? Well, I can go prospectively. I can say exposure, wet ARMD, non-exposure, no wet ARMD. Does that sound reasonable? It doesn't. So my exposure is plasma vitamin C at a particular cutoff, plasma vitamin C below that cutoff, above that cutoff, and I move that into exposure, non-exposure. And my outcomes is wet ARMD, no wet ARMD. Now, the difficulty with this is the difficulty of time and the progression from this particular cutoff to actually manifesting as wet ARMD. So a prospective cohort study might take a lot of time. You need to think about that difficulty there. Now, if I think of it as a retrospective cohort study, again, as the case control study, the issue of plasma vitamin C levels comes. Now, this is keeping aside all the other issues of selection of cases, controls, confounders, bias, all those other things, misclassification bias, selection bias, all allocation bias, all those biases, keeping all of that aside. So you can see the need to actually have a lot of clarity on the question. if you want to move in and get a good design. Your question has to be very clear. And even as your question is very clear, and as you start working on the design, you need to factor in other elements to figure out which design is the best to get you an answer within a reasonable time frame. There are no perfect designs for questions. Well, for some questions maybe, but for most parts, there are no perfect designs. It's a matter of adaptation. Research is a matter of adaptation. Research is a process of reducing the uncertainty in trying to find an answer. And so you try to reduce the uncertainty and try and find the answer. And you have to be open and transparent about it and bring that uncertainty and the ways you reduce that uncertainty into your interpretation of your results. So thank you. I hope this has been useful. But even as I hope that this has been useful, the key point is that it's not going to be useful unless you actually start putting it into practice. So if there is one bit of advice or one recommendation that I would have is that go out and start practicing. It's a known fact that the number of people who listen to courses and lectures and webinars on clinical research methods is always inversely proportional to the number of people who will actually end up doing it. So the key recommendation for me is that all of this does not work unless you actually get in and start to swim. Thank you.
Thank you very much, Dr. Praveen Nirmalan, for that lucid talk. You brought in philosophy to research methodology. Thank you very much for that. If there can be a brief comment, we can go into the next. If anybody wants to make a brief comment of 1 or 2 minutes, then we can go to the next talk.
I think from whatever I heard, it was a very nice and a very illustrative talk. And what has been said in the end really is the truth, that you really require a lot of commitment, perseverance to pursue research for one, and to publish it for another.
Okay, thank you, madam. So if that is all, we will move to the next in line. So basically, we looked at critical evaluation of a paper. We looked at designs. But what we actually require at the end, the final end product, will be a publication. Who better to talk about it than Dr. Namrata Sharma, our honorary secretary of the All India Ophthalmic Society, my own teacher at RP Center. She's professor of cornea. After senior residency and joining RP Center, she went for a fellowship at the Moorfields Eye Hospital. She has more than 300 publications in international peer-reviewed journals and more than 120 chapters in various books. She has authored 6 books by herself. So over to you, madam. You will be speaking to us on the fine art of writing a paper, getting it accepted, the how to manage rejections, how to manage reviews. Over to you, madam. She is conducting a CME right now in AIOS platform. That's why I am requesting everybody to adjust. Yeah.
Sorry about that, and I'm thankful to KSOS for accommodating me. This is a topic which is very close to my heart. If you say what is my first love is research and publications. So and whatever I'm going to be speaking is probably not written anywhere, because it's come out of my lifetime journey, and howsoever and whatever manner I have learned from my seniors on how to do research and how to publish. Given the limitations that were there may be limits of basic sciences, or translational research. But whatever the limitations, this comes out of, the entire presentation comes out of my own experience. So it may be a little informal and may not be that formal. So how to the fine art of writing an article and managing reviews and rejections. I think this is what I have done all my life. So this is something which which is very dear to me. So one is how do you write a research? So research, or how do you write a paper or a publication that you want to do? It can be done by two methods. One is you collaborate with the mentors, collaborators, seniors who are already into it. So you learn these things as to how to do it. Second is that if you're at a junior level, you would begin with a letter to editor or case report, which could be rare presentation, new intervention, or new therapy, or new indication. So novelty is the key to do a research and to write a paper. Anything that is novel, anything that is new will, get published, as opposed to anything that has already been done. So you have to plan a study design if you are doing a large study, calculate a sample size about which very aptly in the previous talk also illustrated, and execute the research or the study that you want to do. Your beginning publications could be, like I said, could be anything. There could be comments, there could be letter to editors, there could be commentaries, there could be case reports. And as you become more and more experienced, you realize that you don't want to publish everything, but you want to do prospective studies, you want to do lab-based projects which translate clinically. You want to do randomized control studies, which will change the practice pattern and the way we do things. So if you're probably at my level or at a more senior level, you would want to do uh, RCTs or randomized control studies, which are going to change the clinical practice. Now, whatever you do, you should know what has already been done. Very important, because nobody is going to publish what has already been done. What are the gaps in knowledge, and how can you fill the gaps in knowledge with your contribution? So again, you have to, if you're planning a study, you have to consult a biostatistician, you have to do get a IRB approval or approval from your ethics committee. And nowadays, some of the journals even would ask you that we need patient consent forms also, like British Journal of Ophthalmology. So sometimes you have to keep them also on record. Then following that, you have to identify and list the measurable indicators for each concept or each part of the study that you have to do. And you have to rewrite the preliminary research question in operational form, which means that you have to write a protocol. And then in that protocol, you have to write how this information is going to be collected and how it will be analyzed. So these are, more, you can say, more structured form of the study design that you've already probably been discussed. Now, writing of a manuscript, it goes as introduction, methods, results, discussion, and references. So introduction should not be too long. It should be short. It should come straight to the point. What are you trying to introduce? What is already known? What are the gaps? What are the research questions? What is the rationale of the study? And few recent references which are pertinent to the study. Don't try to over reference it or put everything. Then in the material and methods, you need to know subjects, technical information, and statistical analysis. So you will recruit the subjects, which could be patients, animals, or controls, with inclusion, exclusion criteria. Period of the study is important. Source of population, whether it is, casualty, or it is OPD, or it is a cornea clinic or any other clinic. Informed consent has to be sought. Also, you have to write that ethics committee approval was obtained. And then table or paragraph with the demographic data should be written. Whenever you're writing equipment, you have to write manufacturer's name, city, address in the parentheses. Procedure should be such that after just reading that thing, one doesn't have to go and, look at anything else. By just reading that procedure, one is able to reproduce it. For established methods, you can reference it, but if you're writing, say, a novel technique, you will have to describe it in details. Then all drugs and chemicals used should be identified, including generic name, dose, manufacturer, and route. So this is just to give example. If you're talking about the ALTK machine, the manufacturer and the place where it is manufactured from. Appropriate statistics have to be done. And then you have to tabulate your results. So whenever you tabulate your results, you have to show absolute numbers and put percentages there, because 90 out of 100 or 9 out of 10 would be 90%, but people would want to know what is the numerator and what is the denominator. Then of course, graphs, tables, figures have to be done, and do not repeat the data which is there in the text. In the data which is there in your tables and figures into your text again. Then The figures, tables, and illustrations have to be in accordance with the journal guidelines. The legends have to be there. The formatting of the figures is important. Nowadays, it's very simple because everything almost is online. So you don't have to take the print form, which we used to take earlier. And do not duplicate the data of the figures and the tables in the text, because that would be repetition. So this is just to show how tables and figures are going to be with the legend, with the footnote, and with all the abbreviations which are there should be, put in the footnote. Then in the discussion, you have to summarize the original research work, emphasize on the novelty and important aspects of the study, start with the major finding, provide answer to question or hypothesis, and do not overinterpret your data. Also, some limitations should be mentioned. The clinical implications of the work is very important. And for your peers who would want to research this later, you must describe the problems, and the list of unanswered questions and possible research avenues should also be given. Of course, one should acknowledge the funding, which may be obtained from a company, may be obtained from agencies such as DST, DBT, etc., or maybe some other people in some other department who help to do the paper but do not qualify for authorship. So all these things need to be acknowledged. Of course, the conclusions have to be brief and they should not be reiteration of the discussion. And generally, the references are not there in the conclusion. Then references, one should do as per the guidelines of the journal. And there are two ways of referencing it, the modified Vancouver style and the Harvard system. So this is one way of doing it in which in fact, almost all the journals would expect you to do it in this manner, which would be there in instruction to authors. And some journals would also ask alphabetically, like you have with the survey of ophthalmology. Now, what is my method of writing an article? I would first tabulate the results. Then after writing the results, I would do the discussion part. So my 90% of the work is over. Introduction can be pulled from the protocol, which you've already written, and material and methods also would be in your protocol. Reference, the day I'm submitting the paper, that day, that minute, I would check for any reference that has come additionally and not copy the references from the protocols and leave it like that. In the end, I would do an abstract, and I'm again emphasizing recheck the references again, because the day you are submitting, there may be two papers on the same thing. Now, after the paper comes back to you, it may be rejected. What do you do then? Of course, you feel disheartened, but I think important thing is that no paper should remain in your laptop, in your desktop. Every paper that you write, case report, letter to editor, should be online, should be on the internet. The moment anything comes which is rejected should be addressed within 48 hours. Otherwise, it will be, in your laptop, and you will feel very disheartened to pick it up again. If your paper is accepted, you have to address both positive and negative comments. So just cut paste all the comments and then answer directly addressing each of the comments. Make changes for a paper which is accepted within a week, but make changes for a paper which is rejected within 48 hours. Delayed reply will result in delayed publication. So do not delay anything. Don't think it is accepted and I can, sit on it for 6 weeks or 8 weeks as the editor has given me that time. I mean, I wouldn't wait for that long. Then when you are delineating the changes, page, para, line, everywhere you have to write where is it, and changes, additions or corrections clearly should be identified in the text like this. Just copy paste this and just say change the title. Okay, the title has been changed. Keywords have to be given. Okay, the keywords have been given, and put page, para and reference for everything and highlight in the text where the changes have been made. Now, rejections are a part of science process, and it is not a reflection on your personal skills or your personality. And it does not mean it is a bad paper. Just means that it was not their priority. So now you have to prove that it is their loss. So you have to address all reviews. Some useful tricks and tips I'll tell you. If it is a surgical technique which has got rejected, you convert it to case series. If it is a case series which has got rejected, convert it to surgical technique. Then you have to look at the paper first, that your data should be accurate. These are some of the reasons why manuscript can get rejected. It was not relevant to journal's readership. Similar publications have already been there on the topic area in the same journal. So do not publish the same topic in the same journal if it has been published in the recent times. Sample size is small, the problem is insufficient or hypothesis is insufficient, inappropriate or suboptimal instrumentation has been used, data is inconsistent, tables and figures are defective, language is poor, grammar mistakes are there, spelling mistakes are there, and it does not conform to the style of the journal. Never make spelling mistakes and grammatical errors. That is something which is in your hand. That speaks poorly of your attitude, and the reviewer just gets irritated if there are spelling mistakes and grammatical errors. But this is just to show the publications that I had, that I have till today morning, in fact, internationally, because I was doing this. So I thought, let me, just like you do for references, check mine also. So I started with international, and the national ones came later on, and these are the publications in the various journals. But I'll just give you some few examples. So anything that comes new, like trypan blue came new, so we published a lot on trypan blue staining. Then phaco came new, so we published a lot on nucleotomies. So refractive surgery came new, so we did a lot of studies on refractive surgery. So you have to be very vigilant. And when you've done so many studies on refractive surgery, then you like to do a review article. So if you've done work in the same field, people will invite you for reviews. This was an invited review. And sometimes you have to tell people that, you know, these are our contributions. And so we would like to start writing a review, and then, you know, they will award a review to you. Power of an idea. Now, trypan blue staining of anterior capsule, which you do so routinely, was first publication by Jarrett Millis done as a letter to editor. So if something is very new, do not wait for sample size to increase, for follow-up to increase, just publish it. Because if you don't put your stamp, somebody else would put their stamp. SLET, described by Dr. Sangwan, came as a case report first, and later on the series came. Tuna packet injury, which we published in Lancet, came as a correspondence of only one paragraph, which was there. So it is important to put your stamp first on something which is unique and innovative. Now, one cornea we are using for 3 patients, we are using for 4 patients, and we are using it in India because we don't have that much tissue. But it was never published. So what you may think you're doing routinely, please check. Some things which are so routine are not published. So one has to be really vigilant. And as soon as we published this in Archives of Ophthalmology, it came in one go, and we didn't even have to, do any revision for that. Now, sometimes you do this went as a case report, and the reviewer said, no, why don't you write a review of literature? So it became a case report and review of literature. So reviewers really help you at times. So this again was a novel technique. And then the reviewer said, why don't you write it as novel technique for so-and-so? So, it's heartening that, the reviewer is thinking from your point of view, which you have not thought of. Now, sometimes it can get tricky. Now this, I'm saying, be vigilant. Anything that you have, this particular technique, we did videos, we won videos for 1.5 hours everywhere, but we didn't publish it. And when we sent it for publication, it got rejected from everywhere. So you have to be vigilant. As soon as you present something, please publish it immediately. Then when you do work in a particular field, then other people who are also there, they make you a part of their collaboration. So you start featuring as with other international authors as well. Now, whenever like new instruments are there, like this IOCT came, we immediately, even there were case reports we started publishing because we knew not very many people are using it. And sometimes, like I said, simple idea, moxiflux for corneal ulcers, everybody was doing, but there was no RCT. And when we looked at it, there was no RCT. So we did this, and then likewise on getafloxacin. Now, when you're doing randomized control trials, always check on the clinical trial website, because this study we conceived, and when we checked on the clinical trial website, there's already a study by Arvind Mutt trial which was going on. So we had to change our study design slightly so that we could make it different. No point repeating a study which is already being done. Now, sometimes just patient follow-up. Now, these were 31 people who fell into a ditch with sodium hydroxide on a single day and came to us 1.5 days later. We had nothing. We just had clinical photographs and their follow-up. And then we published it in American Journal of Ophthalmology, because on a single day, so many people getting sodium hydroxide injury, followed up for 1.5 years, difficult to have this kind of a cohort. So documentation is important. Then, like I said, this unfortunate thing, always publish after you present. So we, fortunate thing rather, this one. So whenever we presented in American Academy, we published in ophthalmology, presented in ASCRS, presented in JCRS. Now, this was the movie that I was talking about, video award at all possible places. But when we sent it to a journal, it got rejected. And then 3 months down the line, the journal project, accepted the same article with a different author. So you have to be very vigilant. You have to be very quick. Then I just want to highlight this example, this article, which was rejected 17 times from 17 places. But we didn't give up. Topical P. fluoxetine in bacterial keratitis, and then finally found a journal where it got, uh, presented. So where it got accepted. So you have to look for specific categories. You have to look for specific journals. You have to change continents. So if you've sent a journal to AGO, Archives, Cornea, it's in USA. Now you change your continent. You let it go to I or BGO, that's UK, because that would have different set of journals, or Australia, because that would have different set of reviewers. So it will not go to the same review. No point sending a journal to AGO and then to Archives and then to Cornea, because the reviewers are going to be same. Then, of course, this is the last part where you need to have continuity in research. So if you're doing corneal ulcer, then you need to, continue the research there, publish, have patents, like we have 2 patents in corneal ulcer, then write review articles, current opinions of ophthalmology, then, review article again after publishing on the same in corneal transplantation. Then again, do a work in a particular field, and then again, review article. This is again featured in current opinions of ophthalmology. So this is how the journey of writing, at least my writing, has taken shape. And I can only tell you from my practical knowledge, from what I have faced and how I have learned it over the last 30 years. So to conclude, no amount of clever writing can cover for a poorly designed research project. However, writing in an appropriate style and presenting a manuscript in a structured, easy to understand format is an art, and scientific writing is a skill which is learned with practice. And this is, I think, very important. All ophthalmologists world over are intelligent. All ophthalmologists think alike. You don't have to be smarter than them. You have to be faster than them in conception of an idea, execution of an idea, and publishing the idea. And I would like to acknowledge Professor Vajpayee and Professor Anita Panda, Professor V.K. Dada, who actually got me into this. And I'm so thankful to them. And I feel blessed to be associated with mentors such as them. So thank you very much for your kind attention. And I would be happy to take any questions that are there.
Thank you very much, madam. You are speaking from your heart, as we could all see. This is what you do best, and this is what you like most. Any brief comments? No wonder you have 300 publications.
Hi, madam.
Hi, Megan. How are you?
It was really a wonderful presentation, and it was a very. I was very enlightened by your talk, which you have given from your heart, rather than we are going through theories. Here, I'm a very young researcher, but what I felt about your talk is like you are talking from your heart and what you have gone through your journey. Thank you so much for your presentation, ma'am.
Thank you, Mary.
Okay, so let's move on to the next talk. So we have seen how publication is done, but before that, we had critically evaluated a paper and looked at designs. Next, we need to manage the regulatory bodies. There are a lot of regulatory bodies. And then we also need to look at the GCP ICH guidelines. So I would like to request Dr. Marin Dixon to honor with that talk. So Dr. Marin Dixon finished her medicine from Georgia, and then Masters in Public Health and Masters in Health Administration from the UK, and worked in London with the flu vaccine and the cancer research for some time. And then she came back to India. She was working as Sanofi as regional clinical trial monitor. And then she's been also training doctors and medical graduates. Now she's joined Amrita as our research collaborator. So Merin, you can start speaking on the regulatory bodies, GCH, ICH, GCP practices.
Okay, sir. First of all, I would like to thank each and everyone for this wonderful opportunity, especially Dr. Gopal. Sir, he's sort of our mentor right now. And apart from him, I would like to thank each and everyone for this wonderful opportunity. So here we all heard about the how to make a proposal, how to publish, how to critically evaluate. But in here, I'm going to talk about the ICH GCP compliance and the regulatory bodies in India. So when it's come to India, especially, this is how we all will think. Clinical trial, is it a trap or is it trustful? How we can trust clinical trial? Because maybe that's my experience, which I have received from India. People are scared of clinical trial. Even doctors are scared of clinical trial. What is good clinical practice? That is GCP. Good clinical practice and international ethical and scientific standard for conducting biomedical and behavioral research involving human participants. GCP is widely accepted and expected in all research involving human participants. GCP is not specific to any protocol, but rather is general and applicable to all the protocols. GCP is like a we can't change according to the protocol or anything. It is fixed and we have to follow if you want to do any clinical research or clinical trial in all over the world. And there is ICH GCP, that is International Council for Harmonization. Considering many principles set out in earlier codes of medical ethics, the GCP guidelines provide a framework for a fair, scientifically sound conduct of research studies involving human participants. The first guideline was dated on 1996. Now we are using the version 2 that has been revised and published in 2016. Here in ICH in GCP, we have CFR, Code of Federal Regulation. How to our last talks, we heard about different sections of our protocol, different criteria we need to follow in publication. Everything will come under our GCP guidelines. 21 CFR 11, this regulates the handling of electronic data, electronic signatures. When an electronic data captured in the system, how the system should be validate our data. 21 CFR 50, the informed consent process. Actually, nowadays, when you are planning to publish also, it is mandatory. Sometimes they will ask for the informed consent letter. Or when you are applying for your ethics approval, they will ask for our informed consent. 21 CFR 56. This section regulates the membership, responsibilities, and operation of IRBs. And 21 CFR 312. This regulates the studies involving the use of investigational new drugs. What additional regulations affects clinical research? GCP is like regulated or is from FDA, like all over the world we follow GCP. But country to country, state to state, we have different policies, different regulation. Especially when it's come to human trial, we have stringent policies in India. In India, we have to follow the Central Drug Standard Control Organization and the Drug Controller General of India, the Department of Health Research and the Indian Council of Medical Research. They have policies and we need to follow any sort of clinical trials we need to try. Statistical is the national authority in India. Statistical is an arm of Ministry of Health and Family Welfare, Government of India. Its missions to safeguard and enhance public health by assuring the safety, efficacy, and quality of drugs, cosmetics, and medical devices. The Drugs Controller General of India is an official of the Statistical who is the final regulatory authority for the approval of clinical trials in India. The Department of Health Research and Indian Council of Medical Research, ICMR, is the apex body that is responsible for the formulation, coordination, and promotion of biomedical research. Key documents in clinical research. First one is Drugs and Cosmetic Act. This act first came into being in 1940 and regulates the import, manufacture, and distribution of drugs in the country to ensure that drugs and cosmetics sold in the country are safe, effective, and conform to essential quality standards. Then ICMR guidelines, released in 2006, is called as Ethics Guidelines for Biomedical Research in Human Participants. This guideline covers two broad aspects of clinical research, the general principle that need to be followed, and guidance regarding the special areas of research. Finally, we have the registration of the clinical trials with the Clinical Trial Registry of India. The CTRI is a free online portal that allows both investigators-initiated and regulatory studies to be registered. In India, if you want to conduct any clinical trial, it is mandatory that we need to register before the publication, or when you apply for a publication, it is mandatory to submit the CTRI registration number. And before the first patient enrolled in the study, it is mandatory to be registered under CTRI. Registration is important for publication as well as the clinical trials. So this is from me. That's all. I'm open for any questions. Thank you.
Thank you very much, Dr. Marin. It was a very eye-opener thing that, we have a lot of regulatory agencies and we need to inform them, get the nod or permission in writing before we start any trial. See, some of these journals ask us, which was your regulatory body? What is the date when you got the regulatory approval? And is the date of the regulatory approval earlier than the inclusion of the first patient into the trial, etc.? Okay. If there are any comments, we can have one brief comment before we start into the next bit of our journey. That is one of the most toughest. And we have none other than Dr. Sabyasachi Sengupta ready for that. So is there any brief comment on this, on regulatory agencies? Okay. So if there are not a lot of other comments, then we'll go to the next talk. I'll just want to introduce Dr. Sabyasachi Sengupta, who is head of research and consultant in the Vitreoretinal Services. And he is in Mumbai. He has a research cum clinical fellowship in surgical vitreoretina from Shankar Nethralaya. Then he was at the Arvind Eye Hospital, Puducherry. Right now he is in Mumbai. And he also had research fellowship at the world-renowned Wilmer Eye Institute, Johns Hopkins University. And he had a lot of awards. He was a recipient of the Venkataswamy Gold in DNB Ophthalmology, which is in 2009. He was awarded the Young Archivers Award. He has published nearly 100 articles. And his Sengupta's Research Academy, he is basically training a lot of people into clinical research methodology. So he has thankfully accepted to cover the most difficult talk of today, biostatistics for dummies like us.
Thank you, Dr. Pillai, and very nice to be with all of you and to be able to discuss slightly difficult topic of biostatistics. I hope I'm audible and the slides are visible now.
Sure. Yes.
All right. Okay. So the name of the talk has been coined as Biostatistics, a crash course. So I think this is what really comes to our mind when we think about stats, and the mind goes kaboom, and This is a lot of the times the fate of a lot of our papers, and simply because we don't understand very simple concepts of biostatistics. So because it's a crash course, I thought I'll show you a quick crash, and then let's try and simplify it. And I usually like to start by saying that the basic building blocks for material sciences is atoms and molecules, right? And we also, of course, know from our own journeys that the basic building blocks for medical sciences are cells. So you can't really understand any of these sciences without knowing these building blocks. Similarly, the basic building blocks for biostatistics are variables, right? So we'll talk a little bit about variables, and almost the whole talk will be based on variables. So statistics really is a science of collecting data, describing data, analyzing data, interpreting and drawing conclusions from data, and predicting future events. And in all the talks so far, you've been hearing about planning the study, designing, evaluating, and other things. So so biostatistics basically helps you do all of that. So we'll quickly take a look at some of these steps and how to do this properly. And I think the last point, that is predicting future events, is really important, because what if you could predict an outcome before it has happened, isn't it? So that is sort of the that is the real thing that almost everyone is trying to do. So we want to predict future events, and statistics really helps us do that. And statistics really finally helps us organize, understand, and make sense of all the data, right? So without biostatistics, we would never know whether a vaccine is better than the other, or whether a vaccine really works or not. So you've been hearing about 90% efficacy, 95% efficacy, and all of that. So all of that is really being derived from statistics. So without statistics, we would never really know that smoking causes lung cancer, or asbestos causes some forms of other forms of cancer. So so that's why it's really important to understand some very basic concepts of biostatistics. So like I said, we'll look at very core or very basic concepts. So what data really means is observations that come from an experiment or research, and a variable is each set of observations in the data set, or in very simple terms, every column in your Excel sheet is a variable, right? So examples are age, gender, BCVA, OCT thickness, number of injections, types of injections, etc. So all of these are going to be classified as variables. So really variables are of two basic types. One is a continuous variable, then other is a categorical variable. And a categorical variable could also be a binomial. So if there are only two categories, say a yes or a no, or say a male or female, so there are only two categories. It's a binomial variable. And ordinal is when there are more than two categories, but there is an order to it, like NPDR. So mild, moderate, severe, very severe, PDR, etc. And multinomial is again when there are more than two, but there is no order to it, right? So that is a multinomial variable. And variables could also be in a different form. You can also think of them as an independent and a dependent variable. This dependent variable is the primary outcome measure, or basically the outcome which is happening, and the independent variable is the one which is influencing, or acting to cause this outcome, or the dependent variable. So continuous variable, really, it's very simple to understand. It means it's a quantity, you can measure it. So variable can take any different values in theory, from lowest to the highest points, or really from 0 to infinity. So age could be anywhere between 1 and 100, or even 120 nowadays, right? So BCVA could be anywhere between 0 logmar, which is 6/6, and say 1.8 or 2 logmar, which is finger counting. So so it's important that these can be measured, and all of them will have a unit, right? So age has years, BCVA has logmar, IOP has millimeters of mercury, central foveal thickness or retinal nerve fiber thickness has these thicknesses in microns. So continuous variables are the ones which are measured. They are quantitative, and remember that they always have a unit to it, and it can vary from 0 to infinity. So these are continuous variables. Next are categorical variables. These are qualitative, right? So they are not nothing is being really measured here. So things are grouped according to some common properties, and the number of members in the group are recorded, right? Again, so it will only have a limited number of values. You can't have 1, 2, 3, 20, 30. You can't have 60 categories in that, right? So you can have, say, 3, 4, or maybe 5 categories, right? So categorical variables are simply grouped together because they have some common properties. So there are no units to this. Simple examples are gender is male or female. Now this is an example of a categorical variable. Success is again yes or a no, so it's an example of a categorical variable. Types of macular holes, type 1, type 2. Types of CNVM, so classic versus occult. Types of injections, Avastin, Lucentis, or whatever you are looking. Types of injury, closed globe versus open globe. So they can only be two. You can't be, can't have any more than that. So these are again examples of categorical variables. And remember that they can be binomial, ordinal, or multinomial. Now, once you have, once you know that there are two basic types of variables, then comes the next job is to describe each variable. So here we are looking at one variable at a time, right? So one variable of the, or say one column of the Excel sheet, we are going to look at every column separately first. So descriptive statistics really means you are describing one variable at a time. Okay, now continuous variables are described in terms of measure of central tendency and measure of spread. So the measures of central tendency that you can choose from is mean or median or mode, and measures of spread are range, interquartile range, variance, and standard deviation, right? So the rule is to describe this, the rule is one measure of central tendency should be accompanied with one measure of spread. So usually mean is always associated or presented with a standard deviation. Median is always presented with the interquartile range, and then you can also present the range along with both of these. So it could be, say mean age is 16 plus or minus 5 and ranged from say 11 to 20 or whatever that it could might be. So that is how you describe a continuous variable. And the best way to graphically represent a continuous variable is a box and whisker plot. So you can ask your statistician to send you box and whisker plots of all continuous variables in your study. And extreme value, why it's important to do this, because you will then identify the extreme values that can be identified from these plots. These are called as outliers, these extreme values. So this is how a box and whisker plot looks like, where the central box, so box and whiskers, so this is the box in the center and these are the whiskers in the on the top and bottom. So the central the central marking within the box is the 50th percentile. The above and below are the 75th and 25th percentile. Then the upper and lower bound are basically, it's almost like a 90th and 10th percentile. It's almost a little bit like that. And outliers, so this outlier, as you can see, is very far away. It's an extreme value. Say for example, your say mean axial length in a particular study is say 22.5, and then you have somebody who has an axial length of 31. Now that is a very extreme outlier, right? So that one value could that one value could really drag all the results toward itself. So we need to understand what we need to do with that outlier. So first you identify the outlier, and sometimes it's a very simple or a silly mistake of data entry. Say for example, instead of entering 30 as age, somebody has entered as 300, right? So that is obviously it's easy to understand that is a data entry error. But sometimes it could be a very so it could be a very extreme value. Say for example, OCT thickness of say 1000 microns, that is possible. And you might actually go back and look at the real OCT and say, oh, this is really that. So you need to understand whether you first is identify these outliers. Second thing is you need to then understand whether you want to keep them in your study or you want to discard them. This is how continuous variables are described, in either with mean with standard deviation or median with interquartile range, and then represented as outliers. Then we look at categorical variables. These are simple to express. These are expressed as percentage or proportions. Say for example, percentage of subjects with more than 15 letter gain in vision. You keep seeing this outcome measure in so many clinical trials. So this is only a percentage, right? So it will be a n and a percentage. Then percentage of patients with mild, moderate, or severe NPDR in a particular study population. Then percentage of males versus females in a study population. So these are categorical variables and examples of them. And the best way to show these are in terms of bar diagrams, or I'll show you an example of that. But it is easy actually. The whole study can be shown in one bar diagram as well. Like I'll show you in the example. And pie charts can also be used, but I usually advise against these because it cannot convey a lot of meaningful information. This is the bar diagram of one of the studies which was published about 4 or 5 years back in the Indian Journal of Ophthalmology. So this talks about different causes of enucleation at a particular institution, and over 15 years is divided into group 5 into 3 tertiles. As you can see, the cause or the reason for enucleation continuously retinoblastoma is increasing, and so as you can see, continuous variables again can be, that's a way of describing them, and then categorical variables, you basically just use proportions and use bar diagrams to show them. Once we have described variables in this manner, so we were looking at only one variable at a time so far. Now it is time to understand how these variables interact with each other. So we are going to look at more than one variable at a time. So there are three basic forms of analytic statistics. This is just to simplify this whole concept. There are of course many more, but just for to start, there are three basic forms of analytics. One is difference between variables, other is correlations, and third is associations between variables. So we'll quickly look at some examples of these. So analysis really based on that outcome variable, right? Now, if you're looking at difference between variables, say difference in age between group 1 and group 2, now that is a continuous variable. So when you're looking at difference in continuous variable between groups, and if there are two groups, then what you use is the student t-test, provided the distribution is normal, right? And if it's not normal, or so there are many outliers, or it's a skewed distribution towards one end of the spectrum, then we use the Wilcoxon rank sum, also called the Mann-Whitney U-test. And when you're looking at differences between categorical variables, then universally we use the chi-square test. And if the proportions are really small, so we are talking about say number of men in group A is 15% and number of men in group 2 is 18%. Now, is there a significant difference in this? What we use is the chi-square test in these cases. Now, if those percentages are really small, so less 5 or less, then we use a modification of the chi-square, which is called the Fisher exact test. So I'll just quickly give you an example. So say difference in mean OCT thickness in eyes with DME treated with Avastin versus IVTA, right? So here the dependent of the outcome variable is the OCT thickness, and that is in microns. Now, so here you would use the student t-test or the Wilcoxon rank sum test based on based on whether it is normally distributed or not. So this is right out from a paper. So I've just copy pasted this. So say that it says that at 6 months follow-up, the mean intraocular pressure in drug A is 11.6 plus or minus 3.2, was significantly lesser than that in drug B, that is 15.2 plus or minus 2.3, P is 0.003. And so this will be calculated using the student t-test, right? So this p-value basically is derived from the student t-test. So p-value, whatever test of significance you use, what you will get the output as is the p-value. And remember that p-value is influenced by the sample size, the standard deviation, and the mean that you're looking at. So here, first and foremost, that really influences this p-value is the sample size. So you have to look at whether the sample size is adequate or not adequate, and then you have to look at the standard deviations as well. As physicians, we usually try and look only at the means, but sometimes the means will be very close to each other and not significantly different, but the standard deviations will be very different. So that is the reason why sometimes p-value may be significant as well. Now, when there are more than two groups, you are looking at more than two groups, and it's a continuous variable, which is the outcome. Then what we use is the ANOVA when it is normally distributed. And if it is the categorical variable, what you use universally again is a chi-square test. Okay, so this is again I'm showing you an example from a paper. So this is a very large study across Europe. It was published in JCRS about 2 years back. So these are the results. I've just copy pasted this to just take you through this. It says 6 weeks post-operatively, the central subfield mean macular thickness was 288.3, 296. So this should be microns. I'm sorry, 288.3, 296, and 284.5 microns in the bromfenac, dexamethasone, and combination treatment groups, respectively. Overall p-value 0.006. Now here there are three groups, right? So there is a so this is basically looking at macular thicknesses. There are three groups: bromfenac group, dexamethasone group, and a combination group. So when you are comparing across three groups, and if it is normally distributed, what we use is the ANOVA, right? So I'll just go back. So this is basically what you have to fall back on. So the more you do it, the easier it gets. So here, so we are looking at differences, and it's a continuous variable because it's a macular thickness has microns, and now we have more than two groups. So the test to be used is ANOVA. Right. So after difference between variables, the other common type of analysis we use is called correlation. So first and foremost, remember that correlation does not imply causation, and it suggests whether one variable is dependent on the other and the direction of the dependence. Right. And it is I'll show you an example. So Pearson's correlation coefficient is the most commonly used metric to show outputs from these analyses. So this is what really correlation means, and it really it varies from -1 to +1. Closer to 0 suggests that there is no correlation. So when the correlation coefficient is closer to 0, it is really no there is no correlation, and that the variables are independent of each other. Closer to +1 suggests that when one variable increases, the other variable also increases. Closer to -1 suggests that when one variable increases, the dependent variable actually decreases, right? So this is generally so let's take an example where the higher the HbA1c levels, the higher the central macular thickness in a particular study. So that is an example of a positive correlation, right? So that is how you will basically look at correlations, and they are usually shown graphically in a two-way scatter plot, and usually it will have a line to show the direction of the correlation. After correlations, third thing we look at is association between variables. So what it really means is, can a particular variable or a set of variables predict the value of another variable, right? We talked about predictive analytics even at the beginning. So so associations analysis basically helps you predict. And in other words, association, the other word for association is regression, right? So these are regression analysis is what we're talking about, and I'll show you different types of regression. The commonest example that we can take for regressions is the SRK formula, where the IOL power is given by the constant minus 0.9 k minus 2.5 L, that is the axial length and keratometry. Nobody in ophthalmology goes through residency without looking at or learning the SRK formula, right? So here in this formula, it predicts the IOL power accurately based on K and L, or the keratometry and the axial length. So how do you think this has been derived, right? So this is exactly what is done in a linear regression analysis. So the output is an equation like this, which we can use. And so essentially what we are really talking about is regression. It helps to determine the value of a variable when the value of other variables are known, right? And it's important to understand here the concept of adjustment and confounders. So someone, I think a couple of talks back, somebody was talking about confounders as well. So imagine that there are many independent variables influence the value of a dependent variable. Which ones are which one associations are real and which ones are spurious is what we are trying to really see. Say cataract surgery has led to increase in macular thickness in group 1 more than group 2. Now if there are many diabetics in one group, then that the diabetic status could also sort of confound this or could influence this, right? So it could be so that the increase in thickness in one group was simply because there were much more diabetics in that group, and it had nothing to do with the drug or the procedure that was being done, right? So just quick sort of just to explain, say you are doing phaco and SICS and you're comparing macular thickness at 6 weeks post-op, and you say phaco group had the increment or the increase is less, and in SICS the increase is more. Now you will blame SICS because and you will say, oh, this causes more thickness, but then the diabetic status could have been a confounder, and that could have actually led to increased thickness in the SICS, right? So to understand and weed these out, we need to do regression analysis. There are two types of regressions essentially. One is a univariate regression, where one independent and one dependent variable is there, so there is no adjustment needed here. And then we look at multivariable regression, where more than one independent variables are there, and they are all the influence of all of those variables on that one dependent variable is measured, and so here we can do some adjustments. So there are different types of regressions, again based on the outcome measure. Like I said, that's why you have to understand whether that variable is a continuous or a categorical variable, right? So if the outcome measure is a continuous variable, say an IOL power calculation, where it is that it can really vary from over a wide range, it's a continuous variable. The type of regression analysis we use is called a linear regression. If it's a categorical variable, the type of analysis we use is a logistic regression. If it's counts data, so this a lot of this is being done nowadays, where people are using trackers, number of steps, heart rates, and so many other things are being measured. So the number of steps you take in a day is really a counts data. So when you have that kind of outcome or output measure, what you use is Poisson regression. And then if you have if the outcome measure is time dependent, say time to failure, or in commonly used in oncology, where time to mortality, or in glaucoma we commonly use survival analysis, where it's time to failure of that trabeculectomy. When outcome measure is time dependent, we use survival analysis, and the type of regression is called Cox proportional hazards regression. So just it's very difficult to go into details of each of these, but the commonest regression that we use is, or you will see in papers, is called logistic regression. It is used when the outcome measure is categorical and binomial, and it is based on the theory of likelihood ratios, and the outcomes are given in terms of odds ratios. So you would have heard, the odds of the odds of getting a particular outcome is 3 times higher, or 1 time higher, or something like that. So our odds ratios are outputs from logistic regressions, and it is completely different from risk ratios. So we're not going to a lot of details of these, but so this is something that you might want to remember, where when the outcome measure is continuous, you use linear. When the outcome measure is categorical, you use logistic regression. When it's counts data, you use Poisson, and when it's time dependent or survival data, you use Cox proportional hazards. Right. So the basic rule basically is that if there is any missing data, then the whole row, that is the entire observation regarding a patient, is dropped from the analysis. Right. So always check the n, or the numbers which are given in the regression analysis. Right. Say for example, phaco versus SICS, and you're looking at outcome which is macular thickness. Now you are using say diabetic status and axial length and so many other confounders. Now suppose there are some missing data about axial length, or there is some missing data about the diabetic status, then the whole patient will be dropped. So even if your sample size is say 200, then you may say that you might see that the regression analysis is based only on 50 patients, because all these 50 had all the data, right? So it's important. So missing data really influences the most, that is influenced by missing data, is regression analysis. So it's important to check whether this is happening or not. So take home message really is determine the type of each variable. So look at the Excel and try and look at every variable and determine whether it's a continuous or a categorical variable. If you're reading a paper, say in a journal club or so, like I showed you, whatever you're reading, think about them as variables and try to differentiate between whether it's a continuous or a categorical variable. Then look at descriptive statistics and describe each variable well. Then look at analysis. So whether you're trying to find a difference or a correlation, and then regression, and then write your results, text, tables, and graphs. And this is my website. I urge you to take a look at some of the modules where, so this is the biostatistics module, so where you learn what is a variable again, then how to make a proper Excel sheet. I think that's really critical for data analysis, to make a good Excel sheet. Then again about descriptive statistics, some analytic statistics, and then some advanced biostatistics, where I talk more about these regressions. And then finally, I think our Achilles is to communicate with the biostatistician, because that's where that crash happens, and it's important to understand some of these concepts. And and also you can take a look at some of the blogs on the website which talk about p-values and more details on regression analysis, and there are many other reading materials which are available to you. So so this is what I wanted to basically convey, and I thought it will be helpful for initiation. Happy to take any questions if there are.
Thank you very much, Sangupta. That is really amazing. You came down to a ground level and spoke to us about it. And probably in your e-learning exercise, you will be doing this a lot of times.
Right.
I'm sure that you'll be doing that all the time. Yeah. If
Right,
there are any
right.
brief comments or queries. So one thing that I want to ask is how often and how much of the biostatistics methodology should we be apply onto the results when we are basically going for a publication? Like, should we actually tell in the methodology once, or in each of the results should we ask which is the test that you have done for association or for any other thing?
Right. So there will be a section in the method section where the end of the method really ends with that statistical analysis. And if it's routine analysis, then you can just enlist, so these are the tests done for these kind of outcomes, and these are the tests which are done for these kind of outcomes. And then in the results, you need not keep repeating that, oh, every time I use the student test or I use the chi-square, you need not keep repeating. However, if you're using some, say, not very common. So yesterday we did an analysis where we used something called a negative binomial regression. So that is something which is odd. That is something which is not well understood. So, you should write, and then you should also give a reference that, this is used before and that's why we are using it now. So that gives some credibility to that. So, but otherwise, I don't think it is important to keep repeating all the time.
Okay. Thank you very much.
All right.
So next on, I would want to introduce Dr. Sengupta's boss, if I were to say so, because he is an associate editor. Sengupta is associate editor in the
Sengupta is the boss.
The real boss. So he's the associate editor of the Indian Journal of Ophthalmology, and now we have the current senior editor of the Indian Journal of Ophthalmology. He's director of National Retinoblastoma Foundation and Department of Ocular Oncology and Ophthalmic Facial Plastic Surgery at the Center for Sight, Hyderabad. Dr. Santosh Shonawar had his basic medical training at Bangalore Medical College. He was a gold medalist from there and went on to RP Center to finish as gold medalist resident. He is a gold medalist all throughout his life. He is gold. So he further trained at the Ocular Oncology at the Wills Eye Institute, USA, and he established the Ocular Oncology service at the LV Prasad, and now he moved on to Hyderabad Center for Sight. So he has about 150 publications and numerous book chapters. Over to you, sir. We want you to select a journal for us, and you as an inside person in IGO will know about what happens behind the scenes and how to get a journal published. Over to you, sir.
Thank you, Gopal, and thanks for the opportunity, KSOS. Wonderful initiative. I have enjoyed the lectures all through the morning. I will talk about two aspects: how to select a journal when you have written up a manuscript, and what goes on in terms of processes within the journal. Choosing a journal is very important for early career researchers, especially those who are at the beginning stage of their or mar, or sometimes it can demotivate young researcher from further publishing. So there are 3 steps to choosing a journal: think, check, and submit. Now, what you really need to think about is whether the journal that you're considering is a trusted journal or not. Is the right journal for your work? There are a lot of research that is getting published, and something that has happened in the recent past, especially after open access publication policy has come up, is that we have a lot of predatory journals or journals which have hijacked the name of famous journals and have modified it slightly, set up dubious websites, and are soliciting publications. We should never fall into that trap. So we have to first check the credibility of the journal by looking at certain indices. Do you know, or any of your colleagues know the journal? Can you easily identify the publisher? And is the journal clear about the type of peer in the journal indexed? And are you clear about the fees that are charged, especially article processing fee? And do you recognize anybody in the editorial board? There are certain tools to select the right journal. These are some of the online tools that are available. You can look at the journal rank, and there is a Cabell's directory of publishing opportunities. There is a Elsevier journal finder, which will give you a list of Elsevier publications. Similarly, other publishers also have journal finders, which may fit in, to which your manuscript may fit into. There is a global serials directory, journal citation reports, and Google Scholar matrices, which are openly, easily accessible. How do you know whether a journal is credible or not? If you look at a particular journal's website, if that particular journal is a member of these organizations, these are reputed professional organizations which any self-respecting journal should be member of, at least one of those or a couple of those. One of which is COPE, Committee on Publication Ethics. If the journal is open access, such as IGO, it should be listed in the directory of open access journals. And for certain countries, there is an alternative source of listing for open access journals. It's called Open Access Scholarly Publishers Association. Is the journal listed in any of these websites? Now, when do you suspect that a particular journal may have predatory attitude? you have to check this particular list. It's called Jeffrey Bial's list to spot scammers. It lists all the predatory journals or journals which have predatory policies. Some of the predatory journals even have ISSN and DOI listing, but they don't know how to use this properly. If the journal doesn't have a ISSN or DOI, then obviously it is not an authentic journal. If the scope of the journal is too wide, for example, if they're publishing anything that is ophthalmology, ENT, and face, etc., in one single journal without any defined objective, then possibly that is a predatory journal. And if you get personalized email seeking for articles, that is the tendency of a predatory journal. There is no transparency about article processing charges. Basically, most of the open access journals currently charge a certain amount of APS. But then if the journal is authentic, the amount of money charged is very clearly mentioned in the website. But if there is no such clear mention of APS, then possibly you are looking at something hidden. If the journal has poor online presence and the journal is not indexed. So if you have a predatory journal, many of these criteria will be fulfilled. Then if you can answer yes to any of the questions that are listed, then possibly it's a good journal. You need to be confident that your chosen journal will have the suitable profile among your peers. That means that if you publish in a particular journal, your peers should be is an authentic source of information. This publication is in a good journal. Publishing in the right journal for your research will raise your professional profile and help you progress in your career. There's no point chasing publications just for the sake of it, just for the sake of numbers, but you have to make an impression, and if that is the aim, your numbers. Your paper should be indexed or archived and easily discoverable. That means that it should be in at least one of the many indexing sources. Some of the newer journals may not be immediately PubMed indexed, but they have a retroactive indexation. For example, we're starting IGO case reports. It is not immediately indexed, but it is a sister journal of a reputed journal. So if it's not an immediately indexed journal or indexed journal, then it should be a sister journal or a core journal of an authentic established journal. Then that is acceptable. But a new journal without any background should be viewed with suspicion. You should expect professional publishing experience when the work is reviewed and edited. That means that there has to be enough feedback from the reviewers. It should not be accepted without any review. It should not be accepted with just a cursory review. And then only you should submit an article. This is a small checklist which is published by Wiley. Again, repeating most of what I already said as to how to choose the right journal. Review recent publication for a candidate journal. Understand that your research work or manuscript will fit into the scope of the journal. Ask yourself if the journal is peer-reviewed. What article format does it allow? Some of the journals may not allow case reports. Some of the journals may not allow review articles or clinico-pathological correlations. You should be very clear as to the kind of manuscript that you have written fits into the scope of the journal and the kind of manuscript that it accepts. Does it have option to pay for open access? That means that if you want open access, because open access is the thing, your manuscript will have wider citation if it is in an open access journal, because people are able to access the full article of your manuscript without having to pay. And that is the easiest way to get cited, because if your article is good and it is easily accessible, then there's a higher chance of it getting cited. Does it allow you to comply with your funders' mandate? Funders sometimes want their funding to be acknowledged, and would the journal allow that? What is the policy on self-archiving? That means, can you archive it on your own websites and your institutional websites? And what are the publication charges? Then look at what the editor and the reviewer are looking at. Aim, scope, and author guidelines. Read the reviewer guidelines. Find out turnaround time. If it is going to take a year and a half or 2 years for your work to get published, by which time it may get dated and others may come out with similar publications on similar ideas, then obviously that is not the right choice. At least if the print publication is going to be delayed, then it has to be ahead of print on internet. So that is again something that you might want to look at. If it's a very popular journal where print time is going to be longer, then AOP is the way to go. And if the target journal offers extra services such as beyond PDF, such as graphical abstracts, videos, and social media presence, all this has to be considered. Now, when you submit, what happens in the journal? There are 3 steps. One is editorial review, production, and finally publication. This is how my desktop would look. It has articles at various stages and the numbers when I open it, and ideally you would like to see 0 in most of it at the end of the day at least, because you want to have a faster turnaround time. Now, when somebody submits a manuscript, we do what is called a technical check. So it's a qualified ophthalmologist who is well trained in research methodology and the manuscript requirement pattern or manuscript formatting pattern of the journal, who would go through the article within 24 to 48 hours after submission and does a technical check whether the article meets all the requirements of the journal technically, in terms of what are the subheadings, headings, and the way the journal article has been formatted, the figures, the tables, legend, etc. And the manuscript is sent back to the author for alteration before resubmission. That means that before the article is touched by somebody who is able to review the subject as such, it undergoes a technical check. This makes the article more robust when it goes for a scientific review. If the article is haphazard when it goes for scientific review, that may be the only reason why it may be rejected. So your article is optimized for scientific review by the technical check. So this is an important process that we follow. This is very quickly done. Once you return the article after complying to technical requirements, it goes to what is called a baseline scientific review. So why don't we send all the articles for peer review? Then the volume of articles that go to a peer reviewer would be too much. So peer reviewers are hard to find, the good ones, and they have time restrictions. So you make the process easier by screening some of the articles right at the time of submission by a baseline scientific review. These are generally very young, reviewers who are very enthusiastic, who are extremely good, and who have some time at hand to do it, say, within 3 to 5 days. So it goes to baseline scientific review, and there we get enough indication as to whether a particular manuscript would stand the test of complete peer review, or should it be rejected at that stage. If it is to be rejected at that stage from the baseline scientific review, it goes to the section editors or the associate editor, who take a decision over and above the baseline scientific review, whether it should be rejected without a formal complete peer review, or it should be sent for peer review. Now, if it is sent for peer review, then it has to go through this process. Peer review is considered to be a very dangerous path for author, but it is not actually so. Peer reviewers are your own colleagues and friends, but you don't know them because it's all blinded. But it might be somebody who is sitting on the same room as you do in your hospital. You don't know that, right? So it may be your own colleague who may be at the same level of qualification. In fact, when we choose peer reviewers, if you have 3 peer reviewers, one is generally the youngest, one is in the middle career, and the third one is at the top of the chain. So basically, we have kind of a distribution of peer reviewers to have the entire spectrum represented. And it is double-blinded. It means that the reviewer will not know who the author is, and the author will not know who the reviewer is. That makes it very simple. If you know either of this information, then it may become biased. So we always remove all the author identifiers and the institution identifiers from the manuscript before it is sent for peer review. These are some of the core values of peer review: fairness, confidentiality, impartiality, expert assessment, security, efficiency, transparency, and integrity. It also means that the reviewer should not take the idea from a particular author for his own benefit and hold back the manuscript. That sometimes does happen, and we are very careful about it. So the peer review process assesses the suitability of the publication for suitability of the manuscript for publication. And if it is suitable, the most important step of peer review is to improve the manuscript by way of helping better interpretation of results, better reasoning of why this particular results came about, better presentation of results and the discussion part, very constructive criticism to help improve the manuscript. Now, peer reviewers are simply not chosen because they are prominent personalities, but we also choose them because they themselves do the review and not pass it on to somebody who's very junior and may turn out to a very haphazard review. Peer reviewers at the end of it fill a form which has very simple questions as you see on the screen, and also submit a detailed report based on which the editor takes a decision. Now, there are three general outcomes after peer review. One is accept without modification, which is very rare. This can still happen for, say, ophthalmic image. So there is nothing much to change. It is a very concise description that the author has given. Images of superlative quality. You accept it without much delay. Second is revision. This is most of the manuscripts go through this process of revision. Revision is not a guarantee that it will be ultimately accepted. If it's a minor review, then there is about 60 to 80% chance that the manuscript will be accepted finally. If it's a major revision without re-review, then the chance of acceptance is about 60 to 70%. But if it's a major revision with re-review, then the chance of acceptance falls to about 40%. So revision does not guarantee that the manuscript will be finally accepted. Now, when it goes to the author for revision, authors have to approach revision in a very constructive way. It should not be, taken negatively at all. I think Namrata spoke about it quite extensively, but I would say that it should be taken as a positively, and all the criticism of the reviewers, however unreasonable it may seem, have to be very politely addressed. You can't be rude about it, because everybody is finally trying to make the manuscript better. If the initial manuscript looks like this, finally it may end up, with all the robustness of peer review and the editorial review, it may end up very good, but fully loaded and up to date. So that's what all the reviewers aim a manuscript to be. And there is no bias as such, so you should not take it in a negative sense. However, some of the reviewers have sometimes rude, and that should be just glossed over, and I wouldn't encourage authors to react to it. Rather than be polite but firm, and you can always counter the reviewer's reasoning, but in a polite way. And rejection may be because of many reasons: technical, scientific issues, very confusing kind of objective, methodology not being very sound or robust, sample size not being adequate to have a conclusion that has been drawn, and conclusion beyond the results of the study, extrapolation beyond the results, etc. So you should not protest a rejection very vehemently, but of course, if you are very sure that the rejection is because of a unsolid ground, then you can always ask for a re-review. This is entertained by the journals, but it should not be a habit, but only when you're very sure that a particular manuscript that you have written has been rejected without much good reasoning. If you look at all the manuscripts, what are the causes for rejection? Poorly written manuscripts are rejected, obviously. Inadequate or inappropriate presentation, poor description of design, these are the most important causes for rejection. Excessive zeal and self-promotion, mine is the first case of this sort, etc., without going into the literature and digging out previously published cases. Contradictory or confusing rationale for the study. Essential data that has been published has been omitted or ignored, and the work is boring and may not be important. We also reject because of ethical issues such as this. If there is plagiarism, for review articles, accepted is about 15 to 30%, depending on how extensive has been the review. But for original articles, it should be less than 10 to 15 or 20%. That cannot be avoided because some of the definitions and criteria for diagnosis, some of the methodologies have standard statements, and that is accommodated. But when the plagiarism is very high, it is seen, and that those are rejected. Apart from that, if there is any indication that the data has been falsified, for example, somebody submits an article with 1,000 cases of ocular surface squamous neoplasia, whereas we know that it is not such a common condition and it takes 50 years to accumulate 1,000 cases, then you know that, well, the data is not really good. And reviewers are very well equipped to identify such kind of falsification or fabrication of data or bloating up of numbers. If there are dual submissions, if there is any image manipulation, if the image has been plagiarized, plagiarized, or image has been digitally doctored to show a finding or remove a finding, authorship misinterpretation, duplicate publication, etc. Those are rejected. Production is a simple process where we do language editing, copy editing, and typesetting, and it goes to the author for a proof, which is supposed to be turned around in 24 to 48 hours. Proof is sent back to the author after correction, and once the author is satisfied and has approved the proof, then only it goes into pagination, and the manuscript is finally published. But is the game over? Certainly not. You have to market the article. Currently in this era of digital medicine, you have to market the article and make sure that you track the impact of your article. Finally, why are you publishing? You make to make an impact. And how do you make an impact? By making more and more people read your manuscript and cite it. That is ultimately the kick is in getting more citations and getting your own author metrics better, such as H-index, etc. I'll come to that a little later. But you cannot just publish and forget about an article. You should also look at the impact that it is making. There are two ways of looking at it. These are global indices: Citation Universal, Scopus, and Web of Science. Impact factor is very well recognized, but for individuals, these are the ones. G-index and H-index are something that we look at. There is also an I-10 index. You can look these up. I don't have time to describe this, but for a journal, impact factor is important. And it is also important to you that you have published your manuscript in a journal of a very high impact factor. That is fine. But what is your individual impact factor is something that you would like to track. You cannot say I have 500 publications. Fine. But what impact have those 500 publications made? And that can easily be tracked currently on Google Scholar by looking at your own G-index and H-index. Your H-index should be at least more than 30 for you to claim that, or you to be satisfied that you have made an impact, and you should constantly aim to achieve that. This is just a way of calculating the general impact factor, which may not be relevant to this talk. But a lot goes on from the time you write a manuscript to decide where to submit, and finally for it to see the light, and for you to become a impactful researcher with a better H or a G index. Thank you so much.
Thank you very much, sir. Thank you very much, sir, for telling us all the inside story. And I think this insight would definitely help a lot of people who want to publish, and that would, in fact, polish their articles quite well.
Thank you.
And now from the editor of the Indian Journal of Ophthalmology, we move to the editor of the Kerala Journal of Ophthalmology, Dr. Sudha V. She's professor of ophthalmology at Thrissur Medical College. She was associate editor of the KJO for 2 years before she took up editorship of KJO. And Kerala Journal of Ophthalmology is going through its multiple tests regarding this thing. So she's basically planning a lot of training program for researchers. So over to you, madam, your plans for the year and beyond.
Thank you, Dr. Gopal, and I'd like to thank COC for this opportunity. Basically, this is an opportunity for KJO. We've just had some very good talks telling us how difficult it is to go in for higher indexing, how much we need to know, how much we should progress. So this is basically my aim, to tell us what we stand, where we stand, and what we should do. Actually, Dr. Santosh Honawar has already told us a lot about how a journal should progress. And so we are really very much at the early stages. So let us talk about what we can do further. So what was our past, what was our present, and what is our future? So as we know, the Kerala Journal of Ophthalmology is a flagship scientific journal of KSOS. It was started as a bulletin in 1974. But we've had some very senior predecessors who have had good visions, and so it was converted into a quarterly scientific journal as a journal of KSOS in 84. And it's only in 2000 that we got our name as the Kerala Journal of Ophthalmology. And from 2006 onwards, we are having digital archives, which is a necessary part for any journal, because your articles have to be reviewed later. And 2015 onwards, we've had an indexing. The first one was the Copernicus indexing, but presently it is now indexed in the Directory of Open Access Journals. So what is our plan for future? Our plan is ultimate aim, of course, is to go in for the highest, that is the PubMed indexing, but we have a long way to go. So right now is our intermediate goal, that is to get included in the global citation databases, because it's these databases which decide how much of your journal is viewed by the international population. And so there are two databases which are available, that is the Web of Science or the Scopus. And after we get admitted to these only, will we be chosen for citations, which are very much necessary for getting into the next indexing. So why is it important to write a good research paper? Now we've had so many talks about all this. So the purpose of publication is to share knowledge. That is true. But it is also there to get recognition of our work and earn prestige. And that is the aim, to get a good citation. So which are these articles which would give you a good citation? So most of them are primary research articles. And these, when you present, they would be subject to a lot of review, especially with external peer review. That is not just the editorial team itself, but it is sent outside. So it will be, you have to write it well. It will be subject to a lot of editorial checks also, to see whether you have gone through it properly, you are actually an expert in what you're writing and you've written it well, and it will be checked for any ethical malpractice. So what is the citation telling you? What is a citation? It tells you that your material has been cited by another article. That is, there is this source that other article has found is from your source. And these citable articles, if you want to increase your citable articles, they are generally original research articles and sometimes review articles, and mostly population studies, they're very popular. So how do these studies get cited? First, they have to be visible. So how do they get visible? Now, all our search engines like Google, and which is what we commonly use, only sort out the first 55 characters of your article, which means your title, your abstract, your keywords. They should be very importantly written, and they should contain. So if your title is, if you want to search for diabetic retinopathy, it should be there in the title, your abstract, or your keywords. And your references and links, the link to this article should be there so that your search engine can easily access it. Only if it is accessible can it be cited. So then, of course, most important is, even if it is accessible, what is the use if that is just a descriptive study which is done 25 years ago in other articles, in other journals? So your content has to have a significant impact. And how you can improve it? If you have a regional focus to it. For example, if you have some Kerala models, Kerala model of health, those things can come into the article and it will become more important and more citable. Also, if you have some unusual content in that article, a novel perspective, then it will be more significant. And not only just writing, you have to say that it is good, well evaluated. So your quality of research has to be good. And for that, if it is a prospective trial or a randomized control trial or the good statistics to it, it will be appreciated by the international audience. And the best way to learn it is to start co-authoring or to help out with a high profile author who knows about it. So you learn a lot from experience with these people. So if you see something, the most cited articles in ophthalmology in Asia, if you come to see it, the most cited articles are your clinical observations and epidemiological studies. So your original research article is important. And out of these 200, 300 studies, if you've seen, most of these are global prevalence of glaucoma, prevalence of primary open-angle glaucoma, prevalence of refractive errors. So epidemiological studies are important. And out of this, we have Indian studies also, like angle closure glaucoma in Andhra Pradesh eye study, blindness studies, the prevalence of diabetic retinopathy. These are all epidemiological studies. So if we can have that kind of studies, your articles which have a high impact will be likely to be cited. So what is our plan? Our plan is to we have to start from the beginning, and that is improve ourselves. So we've already had an inaugural KJO session with all these speakers, which you've just now heard. All of them are experts and they have told you how much of work has to be done. So we've already had this inaugural session on how to publish a paper. And now for our training programs, which we are planning. So it is basically starting from the beginning, how to get ourselves into this mode. So this is very important. COC has done a great job in introducing this topic to us. So let us start with the topic we are planning for KSOS members. That is a basic research methodology training, but it should be practical. So we are emphasizing on practical manuscript writing and choosing what journal to submit it to. So the highlights of this will be understanding the building blocks of a good paper, what all should you include in your paper, and how do you make your paper stand out. And it should reflect your academic and research achievements. That is, you should not just write an article on what you don't know. You should be whatever you are an expert in, whatever you have been doing, all that, and that should be reflected in that paper. And it should be easily comprehensible so that minimal chances of rejection are there. Now, it should not be just for that, because for a journal, we need to also be able to review it. Now, none of us, we are a beginning journal, none of us are great reviewers, none of us are great editors, not like Dr. Santosh Unawar and Dr. Sabyasachi. We are all very much in the early stages. So we should also learn, and all these people who are willing to become reviewers should also learn how to review a paper. So this is our next study, how to training program is how to review the paper and what we should write as comments and how we can modify those comments, how we can suggest those modifications. And of course, most important is whether this is a copy from somewhere else. So we must be able to identify ethical malpractice. And the highlights of this again would be a basic research methodology training. And we will assess the quality, learn to assess the quality of the research question and determine if the study design is appropriate for that question and critically interpret the results and identify if there are any errors in the conclusions which are put there. And final one is for postgraduate students and guides, because they have two purposes. One is research, which is their thesis, and which is very important because these theses are supposed to be converted into original research articles. But most of our theses are very old knowledge. They're already 25 years ago published in other journals. So what is our, this thing is important is to sensitize ourselves to choosing an appropriate topic so that these can be converted into a research article. But it's also important in another way because academics, all published articles need not be very good. Also, even if their articles have given some conclusions, is it important for us clinically? Now, one good example of this is the OHTS study, the ocular hypertension treatment trial, which we know gave us an idea from the phase 1 part of it that all ocular hypertensions, if treated, the chance to progression to glaucoma reduced by 50%. And that is very good. So we are able to think of using this clinically. But the problem was that the conversion of ocular hypertension into glaucoma is very low, while the prevalence of ocular hypertension is quite high in the population. So how many people are you going to treat to prevent into conversion into glaucoma, which is already a low incidence? So to do that, we'll have to start studying in for other risk factors. So that is our critical analysis. So don't just take everything blindly and start your clinical practice. How to critically analyze that article is also very important. So for a postgraduate student, it is important to go into research as well as to go into whatever research you had to critically analyze it and to see if you can go further into it. So these three are our training programs, and this is our KSOS KJO initiative. Please do join us, and we'd like to improve our standards. And thank you very much for all the people who have given us this opportunity to improve ourselves. Thank you so much.
Thank you very much, madam. It's actually ambitious for KSOS and our journal to move forward to higher realms. Okay. Dr. Sai, would you want to comment? Okay, I think Dr. Sai is not here, I think. Okay, so it was a wonderful 3 hours. We are now reaching the end of our session. It's time to formally thank each and every one of you. right from Dr. Santoshan over here, Dr. Sabyasachi Sengupta, Dr. Praveen Nirmalan, Dr. Namrata, Dr. Merin, Dr. Sudha, whom did I miss? Let me just have a look.
Yourself.
Absolutely not. So Manu Raj was the first speaker who talked to us about critical analysis of a paper and literature. And this was a wonderful 3-hour experience. And I hope that we have about 400 playbacks in the YouTube, which means that probably in the next one day, some 400 people will see this program. And I'm sure that this will motivate a lot of people, especially Dr. Namrata's talk, Dr. Santosh's talk, Dr. Sengupta. Sabyasachi, you spoke really well on the statistics methodology. Even very, very basic, even I could understand a lot of things out of that. Thank you very much. And with that, I think we will call it a day. I thank all of you who have, with just one message, immediately said that, yes, we are ready for a research methodology. So this is just a basic primer. I think there needs to be a lot more. And as a country, we need to actually progress in terms of our data, our quality of data, our quality of research material, our designs, our thought process, our honesty, a lot of things that we need to actually make up, and probably collaborating between centers to make a larger data set when you are presenting and publishing. Thank you very much.
Thank you.
All.